Everyone. Today is July 24th, 2024, and it is 4:03 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference. Do we have any? Manager May will be participating via video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I would like to also announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee, Executive Committee, and Board of Managers meeting at a time certain of 5:30 p.m. unless a member of the public wishes to comment on a specific item to this agenda. Do we have anyone who would like to make any public comments on the Budget and Finance Committee? Yes, Manager Valdez.
It's telling me something. Keep my mouth shut this meeting. Are we not going to have any draft motions? Unless I missed it in this?
I don't, there is a motion,
No.
Page?
A motion sheet?
yes. What are you referring to?
Motion sheet? I'm.
Do you have it?
Should look like this. I'll find it. It's not, is it attached to something?
No, it's a single document.
No single document.
David
Thank you.
will provide you one.
Thank you.
Was that your question? Okay.
Thank you.
Before we proceed, I just wanted to share a couple words. I was on vacation for the past 3 weeks, and most recently, I spent 72 hours in the West Bank. What I witnessed cannot be unseen, and the amount of devastation, the amount of destruction, the amount of inequities, and it's unbearable, unfathomable. It's different than what we see and witness on a daily basis on the news than really living it. I lived it, and I experienced segregation, if that's most, I don't know if even it's more than that, walls. And as a person, beyond I'm a public health person or whatsoever, is made me even more committed to breaking barriers and addressing health inequities, because no person, who no matter who they are, should live in those unlivable conditions. So, and I just wanted to share that brief experience with you. The images and the fear and not knowing if you're going to make it or not, crossing the gunshot, the everyday, and you listening to and not knowing what's going to happen the following day. So it's something that is truly humbling, and an experience that I only had to live with it a brief amount of time that really scarred me, but I can only think of those who are living on a daily basis. With that, I just want you all not to forget the ongoing conflict, the war that is happening, and the killing of innocent civilians. So
Madam Chair?
Yes, ma'am.
I agree with you 100%, and have for decades. But I also want us to take into consideration that we have our own border wars occurring here at the southern end of the United States. And I have witnessed the walls of razor wire tearing people up, including pregnant women. And I just want to remind everyone that that's here in the United States, along our border and along our families' lands, that are being walled up to break human rights violations. And I agree 1,000% with
So-
what you were saying and the intent of what you were saying. Thank you.
Thank you, Manager. And I think as a board, we want to break down those silos and walls and to provide care for everyone who needs it. Moving along, I will proceed with our Budget and Finance Committee agenda. Yes, sir.
I mean, I concur with everything each of you said, but I think once we start down this road, it's only fair that I also acknowledge that in the history of this country, people of color, particularly those, have gone through some of the same things. So I just want to note that for the fact that, and we still are dealing with injustices, maybe not to the degree that you're seeing there physically, but in many other ways. So I think I need to acknowledge that as well.
Thank you, I appreciate it. I think to me, it's not just for one specific group. It is for all who is really experiencing injustices. And that is our role as individuals who represent those groups to bring their voices to the table. And that is why I mentioned that. Thank you all for your input. Now, I would like to proceed to the Budget and Finance Committee agenda. Agenda item number 1, approve the minutes of the June 12, 2024 Budget and Finance Committee meeting. I move that the committee approve the minutes of the June 12, 2024 Budget and Finance Committee meeting. I have a second by Manager Valadez. Any discussion? I see none. All in favor? Any opposite? Motion passes unanimously. Thank you. Now moving on to agenda item number 2, receive a presentation on the June 2024 financial statements for Central Health. On this item, Jeff Knodel and Nikki Riley will be presenting. Thank you.
Thank you. Good afternoon. Jeff Knodel and CFO Nikki Riley is going to do the presentation. It's of our June 2024 financials. And just as a reminder, in the packet, we also have included the May 2024 financials. We're not going to present those, but just wanted to inform the board that they were included in the packet. Thank you.
Good afternoon. Wanted to give a presentation on the June 2024 year-to-date financial statements. They are 75% of the year has gone by. And so we'll be looking at how much we've spent compared to that. Nothing really notable happened in the month of June. So I'll just tell you some of the highlights. For tax revenue, we have collected 97.2% of the adjusted tax levy. Healthcare delivery is $166 million for the year versus $112 million the same time last year. And the LPPF total restricted balance as of June 30th is $7.8 million. Nothing really remarkable happened on the balance sheet, so I'd like to skip to the sources and uses unless you have any questions on the balance sheet. If you'll notice on page 5, total uses of budget spent is 52%. And then we'll be able to see the detail of that on page 7. The purchase healthcare services, 58% has been spent on budget.
Is that page 23?
I'm sorry, 7?
Yeah, it's 23.
Oh, is it 23?
Well, it's, yeah.
Okay, 23. Direct services, we've spent 27% of the budget. There are 2 main reasons for that, in that we had 2 clinics that were significantly delayed. Rosewood Zaragoza, which opens, I believe, August 5th. and Del Valley, which is still in the process. And the details of healthcare delivery for specialty care is on the next page. Nothing really remarkable, and that too is 44% was spent. If you have any questions on that, John would be happy to answer those. And that's really my presentation on the financial statements. Nothing really significant happened. Yes.
This is very, just really kind of adding things up in my mind. I'm slow to do that. I was just wondering if it would be possible at some point in time when we get our reports, this is the bottom line for how much we've spent on healthcare, direct healthcare delivery. And everything else we can, I'm sure is going to be self-explanatory, but it gives us an idea as to what is going to actual patient care. And I do understand case management and all the other wraparounds that go towards making a person, addressing their whole person needs. But for the purposes of our budget, I'd like to know what's direct healthcare services and what's not.
The details of that actually will be on the financials next month.
Okay, thank you very much.
You're welcome.
Do I have any further questions? Any comments? Do you wanna mention something related to the 83%? That item, forgot which under what, because it's gonna be related for item number 3. If you can discuss what we talked about during our pre-mate that we did not
could
expend
we-
for
could-
infrastructure.
Could we just, as it regards to these financials, I think we'll bring up
You'll bring it up.
other areas, if there are other questions around
Okay,
those
just wanna make
capital
sure that,
projects. And then as we talk through our FY '25 budget, I think we can have a free
because it's
discussion.
similar,
on that.
okay,
Sure.
no worries. Do we have any further questions on this item? No, if not, no motion is necessary. We'll move on to item number 3. Receive an update on Central Health Capital projects and take appropriate action to approve an increased capital project budget for the renovation of the Hancock Center building. So we are only going to be discussing item number 3A. Members, item 3B will not be considered tonight because it will go first to the Infrastructure Committee for consideration. Then it will come back to us. So the meeting is on August 7th, is that correctly, Manager Matwani?
Wednesdays, yeah.
Yeah, okay, so after that, it will come to us. Well, for this item, Nikki Riley and, no, actually, Stephanie and Nikki will be presenting it. Thank you.
Nikki finds the money, I spend it.
Okay, well, a good match.
On this item, we will be just giving you a status update on all of our projects that are still pending and in CIP, and also asking for additional budget for the Hancock project. The first slide goes over all of our capital projects, what we've spent to date, and that is through June. And actually since inception of the project, what the approved budget was and what is available right now to spend. As you can see, the Hancock Clinical Services and Admin will be asking for additional budget on that. The scope has changed, and the next page shows in detail the categories that we're asking for an increase in budget for. And I'll let Stephanie explain that.
So we'd like to start, when we first asked for a budget authority from you, this was actually COVID. And the property had not been closed. One of the things that you'll notice is that the actual property cost exceeded what we originally estimated as the budget. And then there were certain areas that we didn't have any funding in. I think the other interesting part is that we really thought we were going to focus on the administrative function of the building. And what has changed is, Central Health Equity Plan and really utilizing the site to help deliver additional care and services, clinical services. The lower level, as we like to refer to the basement, is actually still dirt in many portions of that level. So this budget request would allow us to fully finish out and create a real floor on the lower level, which we are going to utilize for many different functions, including housing our joint tech folks, an enterprise, multi-purpose rooms, including a large conference room, where the board of managers will meet, some support functions for those meetings and events, as well as project rooms and some additional space in the lower level. If you'll go back up a slide, that would be great. Thanks. I think also that the ground floor has now a full 75,000 square feet. The lower level is entirely clinical spaces. And that includes some portion for community care as well as some portion for specialty care and Central Health's practice of medicine, shared services, pharmacy, lab, and we're really excited, eligibility, financial screening space that will be shared. We're really excited about this plan, but that was not what the original budget would support. So the other thing we'd really like to point out is that we selected a delivery method for this project. It's the construction manager at risk in terms of bringing a general contractor on board. That general contractor worked with us very early on as we were developing construction documents to really kind of help us set an appropriate construction budget for this project. And if you understand, you've been following, I've been reporting some of the volatility in materials, some of the supply chain issues, as well as just kind of the overall market still in the Austin area. This construction manager at risk delivery method really puts the burden on the general contractor to deliver the project at a set agreed upon price. And then anything that we change or needs to be adjusted, we have to agree on in order to pay the general contractor for that additional scope or that additional change. So I think this is really assuring for us. We've been working with the architects and the design team to come up with what we call this guaranteed maximum price, which is the number, essentially that 106,700 number and the construction line. And so the construction manager at risk is Rogers O'Brien. This sets that GMP, guaranteed maximum price. And we really think that this is an effective way to kind of manage and ensure a project that is delivered on time and on budget. If you have any questions about any of the budget lines in here, please, I'm happy to answer. If you go to the next slide, I think you've seen these renderings, but just so you know, we are hoping to get our core and shell building permit from the city of Austin very soon. We are hoping to mobilize the project with Rogers O'Brien as the construction manager at risk in August. We'll come to you with some potentially more information around a groundbreaking event, that kind of celebration. Next picture, if you want, this is another rendering of the front entryway that faces the Interstate 35. Finally, if you want to see this final slide. Yes. Next final picture, if you see where the letter B is, that is the section that will be impacted by the TxDOT project. So will that A section. We are currently working with TxDOT on those negotiations for that property. As you know, we do expect to have proceeds from both the David Powell site as well as that the convenient care site operated by community care in that B box. Jeff and Nikki will determine how to use those resources towards this project, but they do intend to cash finance the requested funds for this project. And I hope to have your approval on the additional revised budget and the 88.10 million.
Thank you, Stephanie. Nikki, appreciate it. I think what's somewhat assuring is this GMP, the guaranteed maximum price, that there will not be any further asked. So I think that's really reassuring. At this moment, do we have any questions, Manager Valdez? Do you have your microphone on?
Yes, we do, sorry. I wasn't gonna ask a question, I was gonna make the motion.
So, yeah, please go
I
ahead,
move
make the
that the
motion.
committee recommend the board approve the revised capital project budget for the renovation of the Hancock Center building.
Thank you. Do I have a second? Manager Matwani will second.
For the sake of discussion, yeah.
Okay, thank you, Manager Matwani. Any discussion? Manager Jones?
Yes, a couple of things. One is, did you make pictures of the renderings in the handout that was provided?
No, I sent those to Brianna probably an hour before this presentation, so she can send that out.
Okay,
If you
so,
like
so
that.
what we have here are the renderings.
Yes.
Okay, probably would have been helpful to have seen that. The second thing is, in terms of theory, what are we going to do with what we're doing at the I think it's the Buttercrust location, once this Hancock is up and operating?
That site is leased.
So we're leasing that, okay,
Yes,
all right, then,
that site is
that's
leased.
why I want to confirm that. And you feel that the accommodations will be adequate for what we're gonna do there?
I am going to say this. I think we are working to make projections about our future needs. I think a lot has changed from when we started and acquired the Hancock property. And I think we do need to come and make sure that as we plan and grow the system that we are envisioning in the health equity plan, that we do have enough spaces for all of our functions, both clinical and administrative. But for right now, we have the space for the team that is at at Airport in the Buttercrust building, at Hancock, or in other places that we currently own. But I do think that is a very valid point, especially as we make decisions about how we might best utilize some of our assets. Cameron Center, I think we had envisioned having administrative function. I think we need to revisit some of those assumptions and make sure we don't have more clinical need for that space than administrative need, and maybe having other conversations about future administrative spaces.
Yeah, I just think it would be helpful as a board and as a staff that we look at the long-term picture of what we're going to be looking like in, let's say, 10 years.
I am trying really hard, and my colleagues are trying to help with some of this. We are hoping to work through some of that. A lot of it is we're building the plane as we're flying it, but I do think that we are hoping that we can do more of that analysis and have a better sense of what those needs are. I think the CEC is an asset that we're going to utilize when we get it back this fall, and there are going to be some functions that we are going to have to figure out long-term homes for.
Okay, then I just want to make sure you express that.
It's on my things
Thank
to do list, Manager Jones.
What's that?
It is definitely on my things to do list.
Thank you, Manager Jones. Any further questions? Manager Matwani?
So I think it's no surprise that I have a lot of confidence, obviously, in our executive team, just given everyone's caliber and then, of course, empirical performance. And with that said, I don't know if I'm caught. I'm wondering why I feel a little bit caught off guard, and I think that I certainly expected a budget variance. I just think that. So the original approved budget was 62.6, and we're adding 88 to that. So like a 140% additional budget. In my mind, and of course this is not obviously scientific or technical, but in my mind, back in the pandemic when we were doing this, in addition to being flabbergasted at what a great idea I thought the acquisition was, I was also thinking of, I did the double budget thing in my mind, or like, I wonder if that's going to end up being, double budget, and it's more than that. And so we've talked about particularly the acquisition cost, and then all the different kinds of construction, given the changes of our uses. It's helpful to me, and maybe you can just tell me right now, to know what baseline per square footage development costs are for medical space and for administrative space, so I can like just do that kind of stuff in my head. Otherwise, it's arbitrary hundreds of millions of dollars and
So if we take
not
Hornsby
arbitrary, but-
Bend as our kind of, if, you know, that's our starting point, right? Remember I had to come back to you to get additional budget authorization for
Oh,
the Hornsby Bend project, right?
Yeah.
That project, it's a very small site actually, but that project, it has some significant amenities outside of the physical building, right? But it was over $1,000 a square foot.
Wow, okay.
This comes in at 768. The number that we
Okay,
negotiated.
that adds up, just given the bottom floor alone.
Right.
Okay,
So I think that is you know, we know that this project should have had some inherent benefit because it was a built structure, but it also came with some challenges because that building was built in the 1960s. You know, the groundwater had never really been managed, which is part of the reason why that dirt floor had remained dirt in that lower level. It has a grid structure built with these columns, these concrete columns. So we have to wire the building from essentially down those columns. So we can't put any electricity from the ground up on the floors.
And,
So there's
yeah.
just challenges like that. But I think TxDOT, we negotiated, you know, the acquisition of David Powell at $800 a square foot based on our calculations. And I think
oh,
the
that was, okay, so that's right on
68
point.
was right on point.
Well, thank you for that, and, you know, I also don't know if there's a checkpoint learning opportunity for us to maybe look back and see if we were to do like a demo, or were to have done a demo versus not, like what that could have looked like now, just for our own continuous improvement and learning, but you've helped calibrate these numbers for me, and forgive like the lameness in my approach, thank
We
you.
saved about $50-$60 a square foot by having an existing shell, probably.
Still net, oh, okay, yeah, well, that's helpful, thank you.
Right. Thank you, Manager Motwani. Any further questions, Manager Valdez?
Very quickly, thank you for that, Stephanie and Kaylee. Nikki. Sorry. I do remember in the rendering where we were gonna have to have the front going towards the neighborhood behind us.
We do have an entrance that does
That's
go
coming in
from
off
the
that.
back,
But we're gonna go ahead and keep, allow for
the primary entrance.
primary entrance on the 35
Correct.
side. I appreciate that. And as you all make those changes and you put them on, on the website, so that people can see this and look at the renderings and grow, to trust what Central Health is now committed to, and that's the provision of additional direct services, and being more efficient in our use of, tax dollars for administrative services, maybe to go some other place, as we expand the amount of services that patients would be able to access there. That's all.
Thank you, Manager Valdez. Any further questions, Manager Martin?
Thank you. I'd like to concur with Manager Motwani that, you know, this is a dramatic increase in the budget. I know it's hard to say, but what would you, with the issues related to our other clinic build-outs, that this is gonna be the real bottom line prize?
Well, I mean, I
would
do think the guaranteed maximum price approach and using a construction manager at risk was one of our ways to mitigate and push that risk on the general contractor rather than us holding that risk. I do think the other part of this is, I think things have started to settle down in terms of supply chain. We did already issue, for example, a long lead time item. There are some things that are still very difficult to acquire. And so we are really working through. We also, I think, have a better understanding. We have a really sophisticated and seasoned general contractor at the helm here.
Okay, thank you.
Thank you, Manager Martin. I understand and I echo all the concerns we have. It's a significant ask, and over 50% of what we had.
150%.
150%. But the assurance is that GMP that you presented, that we would not have any further surprises. And unfortunately, COVID had significant consequences on driving the cost. At this moment, yes.
Just quickly to confirm, so with this form of contract, I want to make sure I'm understanding correctly. So, the contractor bears the risk, which means that they have to produce and perform according to our specifications, right? That we approve, and they can't charge us anymore. Okay, thank you.
Okay, thank you. So I have a motion at the table and a second. All in favor?
Aye.
Any absent? Sorry, Manager May, I don't see you.
Let me turn on my camera.
Yeah, okay, thank
Aye.
you. Okay, thank you, appreciate it. Do you have any questions or anything? Comments?
Well, thank you for asking, but we're already doing the vote, so maybe it's inappropriate or out of order, but I did have just a little follow-up question from Ann's comments regarding that, but I don't want to take us out of order either from how we do our business.
How is it, the code, can I?
We're in discussion.
Okay, we're still, okay, please proceed.
Oh. Terrific.
You know,
Okay.
Sorry, Manager May, in the future, it'd be really helpful if you turn on your camera so I can see you. I apologize.
Okay.
So I
Oops,
didn't see you.
oops. I thought it was on. Okay, wait. Sorry. Oops.
That's why I apologize for missing you.
No worries, but it's not turning on. I just had it on. There we go.
There you are.
Okay. So just my question was it's just a bit of a follow-up from Ann's comment, which is for Manager Kitchen's comment, which is as we understand it, the cost will as a result of this contract, the costs are now going to be flat as a result of this contract, or can we now take it a little step further, or can we continue to expect that there might be increases as a result of inflation?
I don't know. In fact, that's part of the challenge of this method, this delivery method. The general contractor has to actually try to buy out contracts. We had a long conversation about this morning, and really secure from subcontractors that price. And, you know, they have to figure out how, you know, what the materials cost will be, et cetera. And so that's why they've been working with us now for several months to try to come up with this GMP amount. They really, and that goes down to material selection, et cetera, what the preferred alternates are. And they work hand in hand with the architect to come up with this number. And so, yes, they're saying they can deliver the price and the current construction documents of this project at this amount. And then they will hold the risk on anything that changes. If they're savings too, they get the savings too, right? Now, I will share
Sure.
with you, if we decide, for example, we really want to put in an all-glass elevator instead of a two-sided glass elevator, that is a change on our part. And if we initiate that change, then we will have to add the appropriate funding to support that owner-initiated change, right?
So basically, if there are no changes to the work order as approved today, more than likely the cost to this project should remain pretty stable, unless, of course, we come forward with some, changes that we want. Elevator, we want this kind of elevator or whatever, right?
And if you notice, there was a pretty significant contingency in this project. This is a very large project. It's 196,000 square feet of finished space. If we are expecting to take on any changes within this existing project budget that you just approved, we don't intend to come back to you at all for additional changes to that project budget.
Okay, thank you.
Thank you for your question. And I think that the assurance that we have as board that is the set amount. We should not expect any further requests for this project.
I do have one more question.
Yes, Manager Martin.
I'm sorry. Is this contract backed up by a bond by, or a surety bond by these people? So we line up the lawyers. Okay.
Let me tell you, another project where that's really important.
Okay, thank you. So managers, I just want to make sure if there's not any pressing questions, if we can take this vote because we are very limited on our time today. So I don't see any pressing questions, so moving on, let's start the vote again. All in favor?
Aye.
Aye.
So the vote moves unanimously. Thank you all so much, appreciate it.
And I hope to see you on the 31st at RZ.
Thank you. Managers, we're gonna be proceeding to our next item. and, sorry. And that is receive and discuss a presentation on the proposed Central Health fiscal year 2025 tax rate and budget. Nikki Riley and Jeff Canoto will be presenting. Before they present, just want you to be all mindful of our time today. So this is going to be a lengthy presentation. We have allocated a few minutes towards the end of this presentation for board members who may want to share a few thoughts. So Manager Jones, I understand you have some few thoughts that you want to share, so towards the end of this presentation, I'll acknowledge you. Thank you. So please proceed.
Start working from the very.
Okay, sorry. This is our second presentation of our fiscal year 2025 budget. We're not asking for any action, and what we're planning on doing is walking through where we're currently at. We're still working on a few areas of our budget that we'll bring back at our August 7th meeting. But anyway, we wanted to walk through where we're at today. We've made a few changes, and I will turn the first few slides over to Nikki, and then I'll wrap up. Thank you.
First, we wanted to go over a few of the changes that have taken place since our last budget presentation. The tax rate that we have in our budget is still 6.5% over the no new revenue rate. We did receive the certified roll. However, we just got it, and so we'll be able to update you at our August 7th presentation. What we have seen, though, are actually, I'm on the last, significant increases in FTEs and expenditures has happened since our last presentation. We also did some formula corrections and some housekeeping corrections, and sorry.
Yeah, let me jump in. So as we look at the highlights of our budget, so we're at 6.5%. That hasn't changed, or our no new revenue rate. And as Nikki mentioned, we have received the certified rolls. We'll bring that back. And just as just a thought of some of the highlights of the fiscal year 25 budget, we are bringing on new facilities. Rosewood Zaragoza Clinic is scheduled to open first week in August. And so that you'll see a full year of operations related to that. And then also Del Valle is scheduled to open, I believe, in December. No. Okay. Well, nonetheless, despite there being delays in that, it's hard for us to forecast that, but we are budgeting for that clinic to be open. And then also cash funding of our capital projects. You just approved an increase in the budget of Hancock. The Hancock budget will, our planning as it relates to capital is that we'll spread our capital funding over 2 years on a cash financing standpoint. And we expect to see, because we're cash funding and we're not debt financing that we would see significant savings over the course of a debt issuance period. And then our contingency reserve, so in the fiscal year 2025 budget, we have what's called a structural gap, which means our expenditures are greater than our revenue. And so this will cause us to require usage of our contingency reserve. And so we're estimating that the contingency reserve spend or the decrease will be about a little over $87 million. And then lastly, the Travis Central Appraisal District has notified us that they're seeing a reduction in, a higher reduction in estimated property values that are under protest. And so as a result of that, we would expect to see potentially higher than normal tax payments from homestead properties. And we're working on a slide for that for the upcoming budget presentation in August. So we'll have more information on that. Next slide.
I believe Manager Jones asked us last time to look into the other counties and see what the average tax payment was compared to their income levels. And so we were able to go out there and get data, household income data for each county, and look at that compared to their average tax payment for the year. And so if you notice, Bexar County kind of leads the way in how much their tax payment is compared to their household income. And then you see Dallas is next, Tarrant, El Paso, and then we kind of are parallel to Harris County in that our tax payment is a lower percentage of our household income than the majority of the larger counties. Yes. Do you have any other questions regarding this slide? The next slide is a good slide to note, to just let you know how much we are dependent on taxpayer revenue. If we want additional budget, if we want to be able to add FTEs, especially ongoing costs, we have to have more tax revenue. Last year, I think at this time, our interest revenue was about $8 million lower than it is this year. For the past 12 years, 2 years ago, the past 12 years, 15 years, everything was like at 0.5%, 1% interest. And so we weren't really getting a whole lot of investment income off of the things that Texas we're allowed to invest in the state of Texas. Well, now, since interest rates have increased, we are receiving a lot more interest revenue than in the past. So it's now at 8%. For the past many years, our tax revenue has been at least 90% or above of our total revenue. And I think without the opioid litigation settlement revenue, which is new this coming year, it would probably be around 89–90%. But that's a kind of a good pie chart to see where our revenue comes from. And I believe you've seen the next slide. We've made just all of our housekeeping corrections to this. The clinical support increased a little bit. They're just very minor changes, but you can see how much in healthcare services we're investing in fiscal year 25.
Yeah, I think this is a good representation of the increased diversity and the increase in budget related to our direct healthcare practice. But just keep in mind, this is just a portion of the entire specialty care services that we provide, both purchased healthcare services and our direct practice. And then in addition to that, the hospital specialty care services that are provided. So just wanted to put a context to it that our direct practice is really growing both in size and in diversity of services. Next slide, please. So this is just an update. You saw this slide last presentation. We'll just keep bringing it back as we make updates. It shows actual FTEs and actual expenses by category. And then you see we're estimating in our ending FY24 budget what our pay period costs. So this is a chart that shows a pay period expense. So Central Health has a biweekly pay period, so this is a 2-week period. But the intent of it is just to show the growth of the FTEs, the growth of the pay period spend, and then also if you look at the categories, you see the direct healthcare services is increasing over time, and that's our build as we add Rosewood, Zaragoza, and other direct specialty care services that our spend in that area will increase significantly during the fiscal year 25 budget. Next slide. So our next couple of slides are just the standard attachments that are part of the budget. What we're planning on doing, or what I'll walk through here, is just some of the changes that we've had from last presentation on 6/12. So we're just kind of walking through a couple of the changes. And I just want to pause for a second, and just as a reminder of what I said at the beginning of the presentation, we're still working through the budget process, and we still expect to have changes that we will bring to the August 7th presentation. So it's been a long budget process, but we just wanted to update the board on where we're at currently. So looking at attachment A, just kind of walking through the last column there where it says change between versions, we've added 19 positions, and the 19 positions have increased just through some of the allocations that we have with community care and Sendero. So there's really not a quote new, there's a couple of new positions, but most of these are just through allocations of human resources and joint tech FTEs as we increase our FTEs and increase our spend as a proportion of those allocations. You see on the revenue side a few increases. We've updated our property tax amount just based on some preliminary information that we received. We've increased it by about $535,000. We've made some adjustments on lease revenue. We've added an amount for third-party revenue related to patient revenue as we stand up our direct practice. And then we've also included interest receivable related to the Sendero advances that the board approved related to advancing for our high-risk CHAP program. So we've in that advance of funds in the agreement, we're stepping into a financing arrangement, and part of that arrangement includes paying an interest cost on those funds. So we're estimating that the interest revenue from that is about $1.5 million. And then I think there's a little bit more detail on healthcare delivery, but there are some additional costs of about almost $5.7 million, and then a slight decrease in administration. So overall, the increases in revenue and the increases in expenses reduce our contingency reserve balance by a little over $3 million.
Jeff, really quickly, just out of curiosity, in terms of revenue, you mentioned in your earlier slide something related to the opioid settlement. Where is it under? I don't see the amount.
That's in, I believe that's in other, is it not? It's, sorry, it's a separate attachment that we don't have that in here.
No,
It's
because it's
restricted.
restricted.
Yeah, so it's a separate attachment. We're gonna treat that as a separate fund. And so we'll bring that back to, the board as we, contemplate what the expenditures on it are restricted. So we're not showing that as available funds on the central health budget, but rather separately as a restricted fund.
Okay,
So-
because that original slide that you showed it was part of our revenue, just kind of, I don't know, I was confused, that's,
It is part of our revenue, it's just not part of the unrestricted, budget that we have in attachment A.
okay, thank you.
Yeah, so, sorry for the confusion.
Yeah.
It was all on my part, so don't,
No worries, thank you.
yeah, thanks.
Manager
Oh.
Kitchens, is there something there?
Yeah, I have a question on this page, if that's okay. Maybe I'm reading it wrong, but the ending contingency reserve balance there, is that the amount, is that the line that we should be looking at when we're thinking in terms of where our reserves would be? So at the end of 2024, we've got the 377 million, but we're projecting at the end of next year's budget to be 406.
Yes, that's correct.
So we're increasing our reserves.
So our estimate for 25, our beginning balance is 400. So you're looking at budget, and it's a little confusing when you look at budget and then actual.
Okay,
And I'll be happy to bring something back next meeting to walk through that.
okay,
But kind of the way I would explain it is we're estimating our beginning balance for FY 2025 to be $494 million. And that's about $80 million over
okay,
our budget of the 409.
okay.
And so that's really, I'll talk a little bit about that. So there's probably two really big factors related to why the increase. One is simply, and Nikki mentioned it earlier, the interest income has grown substantially. We did increase our budget in 2024, but there was a lot of discussion about rate cuts at that point. That didn't happen. In fact, rates may have even gone up a little bit. So we're going to see, I believe we had about $7.5 million budgeted. We'll see in excess of $30 million of interest revenue. And this will be typical of any government that holds the type of funds that we have, that invest in things like treasury notes that the governments are allowed to invest in that she talked about. So that part of it is significantly more. And then we've had obviously some construction delays that we didn't know about when we proposed our budget. And so those construction delays have resulted in less spend. So we're not going to hire a lot of people to not provide services and facilities that aren't completed yet. So we have to time that appropriately. And of course, when we were budgeting, we're just estimating when we think the facilities are going to come online, and that hasn't happened. And so that's been a significant savings both on the service side and the clinical support. It's not as controllable, but I think Central Health, as we realized, for example, there were delays in Rosewood, Zaragoza. The healthcare delivery team quickly pivoted and was able to lease some space in Capitol Plaza and actually provide services, but it's not at the same volume that would have been provided at Rosewood Zaragoza. So we are seeing some savings, and in our reserve balance as we go into 2025 will be higher than what we anticipated it would be.
Thank you.
Okay, build
So,
on,
Can we hold on? Oh, sorry, do you have anything?
I was just going to build on Jeff's comments. I know we've mentioned this before, but as we get into this budget season, many of us may receive questions about this. So completing the story of higher than expected interest income and lower than expected costs because of construction delays, we ended up with an unexpected surplus over budget, and we used that unexpected surplus to pull forward key components of the health equity plan that we knew were critical, like the bridge mobile clinic services. Also, the proposal to cash finance part of the cost increase in Hancock, saving us about $16 million in interest expenses on the out years, if I'm recalling your numbers, Jeff.
Yeah, so as it relates to our capital project program, so we anticipate funding $65 million over 2 years. So this year in fiscal year 25, and I'll point out the detail, we'll cash finance 50 million of it. And then in addition to that, the subsequent year, we'll propose an additional 15 million. So we're cash financing it for a couple of different reasons. One, the market conditions today aren't what the market conditions were, especially when we did the initial issue on Hancock. So we issued out a taxable series at right about 2%, I think was the effective rate. I think now I estimated we could probably issue out maybe 4.5%, so more than double that. By cash financing it instead, we estimate that we would save approximately $35 million over a 20-year period. So we're trying to use some of our cash. We're trying to be flexible as it relates to the funding that we have, and we're trying to debt finance when it's appropriate and cash finance when appropriate, and achieve some savings if market conditions aren't conducive to issuing debt. So that's the approach we're taking. Is we're taking an approach that our ending balance was higher than we thought it would be, and so we want to utilize those funds to achieve savings, and then also to the board. I think probably a couple months, 3 or 4 months ago, challenged the team to accelerate some clinical services as appropriate. And to Dr. Lee's example, that's one of the examples of some of the services that have been accelerated over this period. And so that will be the use of some of the other excess funding that we'll have as it pertains to reserves.
Well, thank you for that. So members, I'm gonna have them complete the presentation, and then I'll open the floor for everyone to ask their questions. Thank you.
Sure, thank you. So next slide, attachment B is just the detail, and I'll pick up the pace here a little bit. There's a lot of smaller changes that we've outlined. We are increasing the community initiatives fund by $125,000 to $1 million. And then you see a lot of corrections, just related to timing of some of the direct services that we're providing. And then on clinical support in our direct healthcare services, we have a cohort of nurse educators that are in human resources, and they really fall under the description of clinical support rather than administrative human resources. So we've reclassed those or moved those costs here and take them out of human resources. Next slide. And then the next slide, just on salary and benefits, are just some of those reallocations of joint tech and human resources as we adjusted some of our allocations between central health, community care, and Sendero. We've trued up some of that. And then you see just other adjustments that we've made, just truing up a lot of additional cost in healthcare delivery. And then next slide. And then on our administrative program, we haven't made a lot of changes, but you'll see a couple of adjustments as it relates to some of the changes that we've made. Again, just truing up some cost. And then next slide is our opioid, our attachment C, which is our restricted funds, and there haven't been any changes to that. Next slide is our calendar. And that just lays out where we're at. So we're at our July 24th meeting, and you see some of the upcoming meetings that we have, both in August and September. And then the next slide is our reserve forecast. This is the reserve forecast that we presented as of May 22nd. Another deliverable for the next meeting will be to update this for our next meeting. But remembering if we're decreasing our revenues, or excuse me, if we're decreasing our contingency reserve over time, we're looking at a 7-year period, so there can be some impact on changes that we make that may take us below our targeted days of reserves on hand. But again, this is a 6-year forecast that we'll just have to continue to monitor, but we will update that and bring it back to the board at our August 7th meeting. And then our next slide, next slide relates to staff recommendations related to Board of Managers initiatives. I believe staff has met with all board members that proposed initiatives. And so there are 2 columns here. The column on the left is recommended proposals that are priorities that exist currently. And just as a reminder, I think there was a memo that went out that kind of outlined some of the conclusions of the staff recommendations. And then the proposals on the right are proposals that will either have a business case or they'll have an RFP process in fiscal year 2025, which means it's budgeted for, but it would be a request for proposal or a competitive process as it relates to that initiative. So next slide is just our conclusion of One Trunk, Many Branches, and certainly from this standpoint, just retaining that from a financial standpoint, one of our branches is financial strength and flexibility, and having the capacity to, if any unanticipated events occur, that we have the strength and the flexibility to overcome those.
Thank you.
So thank you for your for your attention, and we'll be happy to answer any questions.
Thank you, appreciate it so much. At this moment, I'm going to recognize Manager Jones, and then I'll open the floor to other members.
Thanks very much for the opportunity to highlight what recommendations I'd made. I think when we began the process of looking at the budget for next year, and there were an area in which I felt that we need to reassess how we're providing services. Currently, we fund services for men of color, particularly the Black Men's Health Clinic and other men of color, through community care. And right now, as my understanding, we roughly have about $1 million in which we're financing that. My thought in conversation with various parties is that it would be better if we could divide that up in half. Our clinical services would be provided, we would continue our relationship and services provided with community care. And we would identify a dollar amount, and I'm not ready to talk about the dollar amount now, but roughly it'd be 50% of whatever we ultimately plan to focus in on this initiative for men of color. The other 50% would be provided to will be contracted with providers, i.e. the Black Men's Health Clinic who's doing it now, or other providers consistent with our contracting relationship to be able to do the outreach, community engagement, and other services for the services that are going to be provided by community care. The thinking being is that community care expertise is in the business of service delivery. The doctors, the nurses, clinical assistants, all of the other laboratory-related services. So the contract and have that operation would be more efficient than to have them to do that and then also contract with them to do the outreach and community outreach activities and services because of the expertise of other providers such as the Black Men's Health Clinic. So my recommendation as we go forth, Board, is that we look at providing that funding that we currently have and perhaps additional funding as we look at other contracts that we have to be 50% for a contract with community care and 50% for either Black Men's Health Clinic or the provider that we contract with for that. So that was the first recommendation. The only other add on to that is that I'm supportive of Manager Valadez Hispanic Family Support Conference. I think it's a very good effort that they're doing, and I'm supportive of that. The African American Family Support Conference has been around for years, but the support has not been to the degree of financial support that I feel that we need or should have. So I'm asking that we consider adding some additional dollars, not to the degree that the family support for the Hispanic, because it's up and developing, but for the conference itself. And so when we start talking about dollars amount, I'll give you a figure at that point. Those are my two recommendations right now for the proposal that I put in terms of our emerging priorities. So
Thank you, Manager
you,
Jones.
Joy.
Appreciate that. Do you have any further questions on the budget as I move, you have the floor right now. Do you have any quick questions?
I don't know if I do have a question about reserves. So I don't know if now's the time to discuss it or later.
Well, I think, yes, this is the appropriate time.
I guess my question is, as we look at our reserves and what you've already clearly indicated because of the market's ups and downs, is there a consideration as we look at the budget of identifying board members a percentage of that reserve that we could augment for service delivery in next year's budget? Now, what that percentage is, I don't have a number, but what I'm hearing from community is that we need to be doing more faster. And I think we're doing a great job, don't get me wrong. But the fact is, could we not enhance what we're currently doing with some of those reserve dollars? How much, I think, is a dialogue for us. But my belief is that we should look at utilizing a bit more of those as we look at the budget. So that's that point.
Thank you, Manager Jones. Appreciate that. So I am going to move to Manager May, and then I'll get back to the rest of board members. Manager May, do you have any comments to the proposed budget? Thank you so much. So I'll go with Manager Motwani. Do you have any questions on the proposed budget?
No, that reserve math that Chair Kitchen and Jeff were talking about earlier, I'd like to go through that maybe offline sometime, just at 80 million, and how that matches back up for the following fiscal. That and so I don't think we need to belabor it here though, unless y'all do. And then that and it's a little bit self-centered, but one of the recommendations that I'd mentioned, and I know that y'all distilled them for brevity, but the one related to AI, it was discussing exploration of implementation of AI, sort of being ahead of it, as well as the ethical implications, but also exploring automation. And both through and not through the lens of ethical considerations, but just exploring automation through sort of a whole, just an overall lens, looking at the organization through the lens of automation, sort of thing, and exploring what the opportunities may be there, irrespective of whether it's AI automation or just automation in general.
Thank you so much, Manager Michelini. Manager Zamora, you don't have any further questions. Manager Valdez.
Yes. One thing I didn't see in the budget, and I'd like to know if there's a way to do that, especially in light of the fact that we're gonna be here.
Chair, I don't know if Cynthia has her mic on.
Thank you.
Sorry.
I mean, sorry again. What about the other contracts that we have with the University of Texas and what they are providing to our targeted population, to our central health population? I'd like to know how much money that is and where is it to be found in our budget, so that when we have discussions with them, we can actually talk in terms of correct dollars that are going to that entity and what are they doing with those dollars with respect to our population. So that's something I'd like to have included or included in our budget. And then with respect to my recommendation on Latinos in the homelessness realm, as to whether or not, and I submitted some information that shows how often that's an undercount with all minorities, not only with the African American population, but also with the Latino population. That's a significant undercount. And so that when people look at dollars received, to be expended in that area, it's also an undercount. What I'd like to know is whether or not we have the ability to make sure that we increase funding for our partners, or hopefully to be partners that are specifically dealing with homelessness and marginalized populations, such as Community First and others, because we are watching economic changes occur that is going to even more greatly impact our communities, and environmental changes, climate changes that are going to put more people in the street in a period of time when it's either too hot or too cold. So I'd like for us to make sure that we get that included and upped. And one more thing, with respect to the Latino Conference, I just wanted to give you all a brief. I had met earlier with Ted and Yvonne and Bedla, and I just want to give them a thanks and a heads up for the work that they're doing to make sure that our underserved population that doesn't speak the English language, of which is more than 50% of the population that we serve, really is in great need of resources, and especially the uninsured who are not participating in our programs and are not being enrolled. So if we can look at expansion of education and enrollment services in those areas. Thank you.
Thank you, Manager Valdez. Manager Martin.
Thank you. One thing, I had a question about the opioid money. Is this part of the Purdue money? Is it separate? Is it the same litigation? Because that's been thrown out.
I don't know. It's funding specifically related around healthcare, health hospital districts. And
Right, Jeff, what I'm asking is this money coming from that Purdue settlement, or is it coming from some other source?
I'm not sure.
Because that's been thrown out.
I don't know that
I'm
it's
just saying
the
for
Purdue
financial-
settlement. It might be some other, let me look at that.
It's not a ton of money, but I think we're
Right.
gonna say that it's there.
Right.
Another thing I'd like to second what Manager Valdez said about, I think, doing some analysis of UT. But I would argue we also need to do analysis of sort of cost per patient and efficiencies of every clinic. Rosewood, Zaragoza, Blackman's Health, all these differences, sort of see what are we getting bang for the buck and where inefficiencies might be. I know that's legwork for you guys, but I think it'd be very beneficial for us to see that. That's all.
Absolutely. Thank you.
Thank you.
Thank you.
That's a good point. Thank you, Manager Martin. Manager Brinson? Do you have any questions or comments?
No, I don't think so.
Thank you so much, Chair Kitchen.
Just very quickly, I wanted to thank all the board, members and, for the process that I think we followed this time in terms of the board submitting ideas. I thought there were some very, very helpful, constructive ideas, and I also wanted to thank the staff for the way that they responded. And what we have now is a deliverable from the staff, which is this document, which takes into account what people recommended. My understanding is this goes into the budget. And, you know, at a later date, we'll talk about what that means in terms of dollars. But my understanding is that these particular projects do, and some of them are things to be developed over time in the right side of the, you know, the business case of the RFP. And in the case of what you mentioned, Manager Montwani, you know, in terms of looking at automation and AI and that kind of thing. So, so anyway, I just wanted to call out, I'm sure we can improve this process next year, but I felt like it went well and wanted to thank everybody for their participation.
Thank you, Chair. I echo that sentiment as well. Thank you all, everyone, members and staff. This so far feels like a smooth process versus other years, and I hope everyone's voice was heard and listened to. Yes, Manager Valdez, really quick.
15 seconds.
Okay.
15 seconds. I'm sorry, excuse my ignorance. In the chart that you gave us where you had the index and there was 3 little boxes, I didn't see one for peach. The peach color, that was in the last 3 years. I didn't see what that was down here, in the legend. And just curious. Yeah. Here, number 60.
Yeah, so,
You see the peach color, 1, 2, 3? And I didn't see it included in a legend down here, so I thought maybe I'm missing something, or is that
yeah, so,
existing? I didn't know.
so there's a couple things going on this chart. The colors to the left that are solid, those are actuals. Can I call them shaded colors on the 3 bars on the right? Those are estimates. The numbers that you see on top of the bars, those are FTE numbers. And the line that you see is just the line of FTEs, the trend of growth.
Okay, I'm sorry, I didn't hear what the peach meant.
Beach is the orange, estimated future orange. So estimated future direct practice of medicine.
Future direct healthcare services.
For me, I'd like to see a little box that says that, so that I'm not assuming that it's a number that I don't know what it is for.
Okay. Thank you.
Good point. We'll do it.
Thank you all. Thank you, members. Now moving on to the final. There is no motion for this agenda item. Now moving to our final agenda item. Confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, August 7th, 2024 at 1 p.m. or immediately following the Infrastructure Committee meeting at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. I have a first by Chair and a second by Manager Valdez. All in favor? Meeting adjourned.
Aye.
Thank you. So,
Okay, managers, good afternoon. Today is July 24th, 2024, and it is 5:21. As a quorum of the Executive Committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. I also like to announce that we'll hold public communication for all the committees together at 5:30 at a time certain. So we're now going to proceed to the Executive Committee agenda. The first item of business is to approve the minutes of the Central Health Executive Committee, June 12, 2024. I move that the committee approve the minutes of the Central Health Executive Committee, June 12, 2024. Do I have a second? Second from Manager Brinson. All in favor? Okay. We'll move on to item number 2. Review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. So Brianna, I think, will be presenting for us. And on this item, managers, there will be no motion necessary. We're just, Brianna's presenting for us, so go right ahead. Thank you.
Yes, okay, I'll start with a reminder that tomorrow we do have a Travis County Commissioners Court work session. At 1:30, I believe, we'll be presenting around 2.
I just got word it might be 2:45.
Okay,
2:45, okay.
And then next Wednesday, we do have the Rosewood Zaragoza Grand Opening and Stakeholder Tour, and that's at 9 a.m. And then for August, I'll just go over, so for August 7th, there are a couple of changes on strategic planning. So Integral Care Joint Work Update and the Funding for Diversion Services Update will be moved to September. And then we're gonna take off the Navigation Center update for that. Everything else should be the same. And then we also have Travis County Commissioners Court work session on August 8th. And then on August 14th, we'll have our public hearing. And then August 21st, all of those items are the same as of now. And then again on August 27th, we'll have Commissioners Court public hearing for the performance audit. And then on August 30th, a reminder, we'll have the Central Health 20th anniversary event.
What time is that?
That is from 11 to 1:30.
Okay.
And that's all I have, unless there are any questions.
Any questions, anyone?
I have a question. It doesn't relate to what she has. It's following up on my routine question about our planning for our retreat.
We have a date for our retreat, which I think is October 23rd. And we sent out, if I'm remembering correctly, someone correct me if I'm wrong, and we also sent out a memo with the agenda items on it, and ask everybody to send us any comments they might have about those agenda items. So we didn't talk about it in the board meeting, we did it offline.
Well, I think it was talked about June 12th, right?
What'd you say?
June 12th, briefly at the executive committee meeting, it was brought up.
Well, we may have
Yeah.
brought it up then.
Yeah.
Yeah, thank you, Brianna.
Yeah,
I
it
was
was in
trying
that
to
packet,
remember.
the memo was in that
But-
packet.
Yeah.
But you said there was an email that has been sent out with that?
Brianna, do you want to speak to that? There was a memo sent out, right, with the agenda?
The memo was provided in the packet, we didn't
Okay.
send a separate email. Yeah.
Okay, we can send that out again. It
Yeah,
sounds
I
like,
appreciate it, because somebody.
let's send it out again with a reminder for folks to give us any comments that they have.
Okay.
Okay, we'll do that.
Thank you.
Okay. I'm not seeing any other comments, so I'm going to move on to our last item, which is confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, August 7th at 1 p.m. or immediately after the Budget and Finance Committee at the offices here. At this time, I'm ready to accept a motion for adjournment. Motion for adjournment, second? Second, okay, all in favor? All right, we are adjourned. So we're now gonna move on to our next meeting, which is the board meeting. So good afternoon, today is July 24th, 2024, and it is 5:26. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. I'm going to pause just a second here because at 5:30 we're going to start public communication, which means I have a few minutes here. I wanted to point out to everyone that we probably will go till about 9 o'clock tonight. I think we passed out to everyone this document, which is just so you'll know, your officers are trying to time things ahead of time so that we can get through things at a reasonable hour. But we wanted to share that with everyone so that you all know what we've estimated in terms of the amount of time for each of the agenda items. So you have that. Now, the purpose of that is just simply for planning, for moving our meeting along. It is not to stop any conversation. So at any point, if we estimate wrong, and we'll keep talking if we need to. But the point of it is just to help everybody understand what the rest of the evening looks like.
Just wanted to congratulate you because we're on time and a little early.
I think we need to congratulate Maram on that. Thank you very much. All right, I'm going to go ahead and read in the public communication because by the time I do that, it'll be 5:30. So, all right. We will now receive public communication for our Budget and Finance Executive Committee and the Board of Managers meetings. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with the Central Health via the online form or by telephone no later than 1:30 today. Today as part of our public communication, we're going to continue with our mission moments. With these brief presentations, staff, patients, or community members will share with us stories of how our mission is connecting people to health care and health coverage and giving them an opportunity to live healthier lives as Central Health builds a better healthcare system for Travis County. So today, in our meeting today, we're going to have a video where Central Health's Dr. Michelle Lubetsky shares a story on how she eased a patient's hesitancy when making an important decision regarding starting dialysis. So I just want to say that I really appreciate the Mission Moment series. It really helps me, and I'm sure I'm speaking for our board, helps us understand what you all are doing day to day, and we really appreciate that. So I'm going to open the public comment period. Yesenia, can you please introduce any public speakers for this evening?
Good afternoon. We have not had anyone sign up for public comment today.
Okay.
Thank you.
Okay. Then do we want to take our mission moment now?
Yes, please.
So let's go ahead with that. Okay.
Months ago, I was asked to see a patient to see if he was going to need chronic and ongoing dialysis. The patient had been seen in the emergency room and was found to have new onset of kidney failure. He was told by the doctors in the hospital that he was going to need to be on dialysis for the rest of his life. He told them he did not want in any circumstance to start dialysis, so they discharged him home and he had a follow-up visit with me. Unfortunately, there were a lot of barriers to him getting adequate care in the hospital and a lot of difficulty for him understanding what does dialysis mean, what will it mean for the rest of his life, and unfortunately, because English was not his first language, there was a lot of confusion over what had happened when he was hospitalized. He came to see me in the clinic and we spoke a lot. We spent probably about an hour talking about what is dialysis, what does it mean, what's the lifestyle like of people who are on dialysis, and we talked a lot about kidney failures and all the different options to replace your kidney function when your kidneys no longer work. These options include 2 different types of dialysis as well as kidney transplantation. I saw him a few weeks later. He had time to think it over. We had a second discussion, again, about the types of kidney replacement therapy. What does it mean to be on dialysis? He asked a lot of questions. Our team here at Central Health consists of myself, a nephrologist, but then we also have a nutritionist, a social worker, a community health worker who provides dialysis education and chronic kidney disease education. In between the first visit and the second visit with me, he saw our entire team, was able to speak to everybody, learn about what are the things he can do in his life that will affect his progression of kidney disease, improve his lifestyle, whether he is or is not on dialysis. He was able to learn more about the modalities of kidney dialysis and also learn more about the potential for kidney transplantation. By the time he had his third visit with me, he'd actually researched types of dialysis on his own and was actually excited to start. He'd talked to friends who'd been on dialysis. He'd talked to our community health worker and had more education. He'd spoken to our nutritionist and had a health plan and things he was eating and not wanting to eat to improve his health. And I think we took a patient who was, unfortunately, after his hospital discharge, completely depressed, not wanting to go on, not wanting to do any medical treatments that would be life-saving, and suddenly he kind of had a new outlook on life. He's going to be enrolled in our transitional dialysis program. We're going to find a way for him to do dialysis on his terms now that he understands more about the procedure. And hopefully, when he's able to enroll in some of our other programs, he may even have the possibility of kidney transplant in his future.
our thank you? What'd you say? Okay,
Okay.
excellent, thank you.
Chair?
Yes, go right ahead.
Well, thank you for that. That's amazing. I have a quick, out of curiosity, she is employed by Central Health, one of our employees, because I saw or she, the affiliation with UT. Okay, cool. Thank you so much.
Okay. Okay, managers, we'll now proceed to the consent agenda. A reminder that for consent item C3, the Budget and Finance Committee recommendation is only to approve the revised budget for the Hancock renovation. The CEC renovation will be considered first by the Infrastructure Committee, and the budget will then be considered by the Budget and Finance Committee in August before coming back to the full. Number two, that we recognize and celebrate Integral Care and Community Care for their outstanding achievements in pursuit of the HEI designation, especially their newly obtained high performer designations on the 2024 Healthcare Equity Index. Number three, that we extend our heartfelt gratitude to People's Community Clinic for their role in providing technical assistance, expertise, and guidance to the cohort, contributing to the successful outcomes of this initiative, and commend them for retaining their high performer recognition. Number four, that we also commend Vivint Health Texas and Austin Public Health's RBJ Health Center for their commitment to equitable health care for the LGBTQIA plus community and their recognition in the latest 2024 Healthcare Equality Index. Number five, that we acknowledge the collaborative efforts of all individuals, volunteers, and staff involved in this initiative for their relentless dedication to improving healthcare outcomes for the LGBTQIA plus community in Travis County. And finally, number six, that this resolution be documented in the official records of Central Health and shared with the respective organizations as a symbol of our appreciation and support for their invaluable contributions to health equity. So I believe that we have a motion in order. Would someone like to make the motion? Make the motion by Dr. Musaitis, second by Manager Valadez. Oops. And Dr. Brinson? All in favor, please say aye. Aye.
Aye.
Resolution is passed. Thank you all very much. I think right now we can take a break. We'll take a break until 6. And I don't know if you want to take pictures. You want us to take pictures up here?
I just wanted to say one last thing.
Okay, yes.
I remember reading a study or something that had just come out from at the federal level, and they were talking about how they were going to want everybody, all health centers and hospital districts, et cetera, clinics, to diversify their workforce so that they were reflective of their communities, and they provided, I guess, some kind of proof or evidence base that this was the best way to address the needs of their patients and to build trust with their patients. I was just looking for this study and I couldn't find it, but anyway, it's out there somewhere. Thank you.
Thank you, Manager. Okay, let's see. Do you want us to, Ted, you want us to stand up or what? Yes. Oh, do I need to recess? Okay. We are recessing the Board of Managers meeting at 5:46. We'll reconvene at 6. We're gonna reconvene the Board of Managers meeting at 6:01. And we are going to item number 2, which is receive an update from the University of Texas at Austin-Dale Medical School on current and future collaborations with Central Health Care and Services, provided consistent with Central Health's mission and related reporting for the current fiscal year. And we have the dean with us.
Great, so am
Thank
I
you
up?
and welcome so much for being with us. We're
Thank you.
all really looking forard to hearing from you and
Thank you,
talking
thank
with
you.
you.
And let me just make sure that before I get going,
Okay?
I make sure all the techno, are we good? Well, they're working on that. First of all, good evening. I'm Claudia Lucanetti. I'm 18 months into my role as the Dean of Dell Medical School and the Senior Vice President of Medical Affairs. And I can just preface by saying this relationship with Central Health is a really important relationship, and one that I hope, as you see through our presentation today, demonstrates our commitment to our shared goals to addressing the health disparities within our communities, to working and partnering together to really be open and transparent about making a difference, making an impact here. It's my pleasure to talk to you tonight about the progress we've made in that space, the impact of that partnership, the benefit I think that hopefully you'll be able to see from that partnership as we continue to really optimize and collaborate, because that work is never done. In fact, everything we start just brings more to do, but again, that relentless focus and partnership is central to our goals together. I also want to thank our President, Patrick Lee. It's really been such a pleasure and honor to be working, collaborating with you. I think we have a lot of shared values and North Star together. I think that's been demonstrated in just the type of conversations we've had and the work we're doing together. I also want to thank Chairperson Ann Kitchen for the opportunity to work with you as well. And again, I also want to thank all of you and your service on the Central Health Board, the commitment you've made, the dedication you have, and also the importance of holding us all accountable about what we're actually doing in our communities, because I think it's often easy to talk about the impact of the work we do. It's more important to also demonstrate that impact and continue to be really driven to continue to drive to the types of solutions that we think are important for our community and the health of our community. I also want to thank our many partners throughout our city, the state, the nation. None of us is really as successful as we are together. And I also have several of my colleagues here from Dell Medical School that I want to thank for their, not only their commitment to the medical school, their commitment to Central Health and our shared mission, but again, for their support over these 18 months in this role that has continued to expand, and I look forward to telling you about that. We do have a lot to do, a lot to be proud of, so we will both celebrate and set a vision for this evening. So I will advance, hopefully, my next slide. So before I get into the presentation, there are a couple of important points I wanted to make to the group today. The community's visionary investment in Dell Med is substantial, and in addition, that investment is incredibly generative. There are many examples, and we'll highlight some of those this evening. As you will see when I talk more about our strategic plan in a few minutes, that's the strategic plan for Dell Medical School. We're in a new chapter for Dell Med. I often call it Chapter 2. It's a big chapter. There's a lot going on in that chapter, but it is one where I hope we will continue to realize our potential as an academic medical center, but one that has been birthed within the community and will continue to be committed to this community. I get excited when I talk about how academic medicine converges research breakthroughs, the best and the brightest physicians, and the advancements in the care they deliver. But importantly, in academic medicine, in this area in particular, we recognize that the city of Austin is one where it has incredible disparities in health. And as we think about building to the future, we cannot do that without a continued commitment and recognition of how we're going to address the challenges we face together. I think it's also important to recognize that as we enter this Chapter 2, we are not changing our mission, which is to revolutionize how people get and stay healthy, not just some people, not just a few people, all people. We'll continue to work with partners like Central Health to improve health and healthcare for everyone in Travis County. And we're continuing to invest in efforts such as clinical services and residency programs as a reflection of that partnership. And this evening, I want to review our core areas of collaborations to close our gaps in healthcare, from prevention to access to quality of care and to caring for those in need the most. And as we'll talk about some key community initiatives still gaining momentum, aimed at cancer control and the continuum of care for people experiencing mental illness, homelessness, and or both. So as far as our next slide here, first of all, a few notes to focus our discussion. The DelMed Central Health Affiliation Agreement was signed 10 years ago, and it promises local community support of $35 million per year for the direct support of the UT Austin Dell Medical School. It also specifies a number of affiliation goals. Those include to expand the healthcare infrastructure for the region, to increase access and improve quality of care for our patients, and to provide for funding for a medical school, which is necessary to have a higher functioning academic health science center level teaching hospital. You can see here the commitment from UT System at $25 million and the community support through Central Health of $35 million annually. This next slide is a summary of the permitted investments outlined in the affiliation agreement. And this is really funds to support the continuing investment in programs, projects, operations, and provides that further the missions of the Central Health and benefits the UT as well as the Dell Medical School to comply with all the laws that apply to each party. What do those permitted investments include? It includes the enhancement of medical services for residents of Travis County, directly or indirectly increasing the healthcare resources available to provide services to Travis County residents. It's also the discovery and development of new procedures, treatments, drugs, and medical devices that will augment the medical options available to Travis County residents. And finally, the development and operation of collaborative and integrated healthcare for Travis County residents. They also include direct operating support to UT to facilitate and enhance the development, acceleration, accreditation, and ongoing operation of the UT Austin Dell Medical School and its administrative infrastructure. I would comment that we just on July 22nd submitted our LCME accreditation report. That is to lead toward the full accreditation for the next 9 years, and we will be having our site visit in October. It was really an honor to see just the accumulation of achievements for the medical school. We look forward to hopefully sharing with you the successful accreditation. In addition, permitted investments include the recruitment, retention, and work of the UT Austin Dell Medical School faculty, residents, medical students, researchers, administrators, staff, and other clinicians, several of whom we have here tonight, as well as other related activities and functions as described. Here is a summary of DelMed's reporting aligned with the affiliation agreement. Several examples that relate to providing additional operational and clinical quality reporting on services. Examples include patient service and volumes, patient demographic summaries, standard utilization data for services provided, average times between referrals and appointments, appointment and procedure no-show rates, hospital transfers as a percentage of total ambulatory surgery center-based cares, surgical site infection rates, patient satisfaction, promoter scores, surgical cases with unexpected findings at the time of surgery, condition-specific patient-reported outcome measures. Again, these are just some examples of the type of data that we continue to provide. This is really just showing some of the milestones reflecting both our partnership and for the medical school. We began educating medical students in 2016. So although the school really opened in 2014 and we began and celebrate our 10-year anniversary this year, in fact, with the graduating class, the first class actually began in 2016. It's a lot of work to get a medical school up and running. And after taking over sponsorship of existing medical education programs, which train physicians in a specialty or subspecialty, that occurred in 2015. We opened what we refer to as UT Health Austin, that is the clinical practice of DelMed, where more than a third of patients use MAP, Medicaid, or Medicare. That was opened in 2017. And that same year, we entered into our first master services agreement, giving people with low income access to musculoskeletal and women's health care at UT Health Austin. In 2020, we worked together with Central Health and others across the community to respond to the pandemic. I think that was really when you saw the power of collaboration, the importance of a medical school, and how it really nucleated many of these activities also for the university. I think in that pandemic, we co-created a center of excellence at Del Seton Medical Center that at one point had Del Seton patients surviving at twice the rate of other COVID-19 patients across the country, and working closely with the city, community care, ECHO, and others to ensure that COVID-19 care and other supportive services were available to people experiencing homelessness. By 2021, we had doubled the number of GME residency programs over the count we first started sponsoring in 2015, and as of last year, we've actually tripled the number of programs. That same year, we jointly recruited our colleague Alan Shalsha to the role of Chief Medical Officer, and we are proud to have him as an associate professor in DelMed's Department of Population Health. This year, we've implemented a broader co-recruitment strategy that I have an opportunity to talk to you all about a bit later. And in addition to starting to work to establish a community-wide care coordination platform that will change the way we care for people here in Travis County. All that is to come in the next slides. In addition to those milestones, Dell Medical School achieved a number of accomplishments that are defining the future of health in Travis County. We have recruited 445 new doctors to Austin, added 86 faculty involved in research with over 132 million in sponsored research projects. We graduated more than 230 medical students, and we're now training 465 residents and fellows who provided over 900,000 hours of care in our community each year. And when you think about all that in that period of a decade, with the first class in 2016 and a pandemic, I think that's pretty remarkable numbers. All of these milestones, however, and accomplishments are enabled by our partnerships, and not only with Central Health, but with Community Care, Integral Care, Austin Public Health, Ascension Seton, Lone Star Circle of Care, Austin Community College, Michael and Susan Dell Foundation, and many more. And as I said a few moments ago, academic medicine is where research breakthroughs, the best and the brightest physicians, and the advancements of the care they deliver converge. And I actually showed this slide last year. We've updated it with a few additional things, but I think it's important to recognize names and titles are one element, but the ability to have people in major leadership roles in this country means that they can carry our vision, our mission, the work we do here nationally at a scale that is hard to do locally sometimes. This is enabled in a big way by this partnership and also by the talent we recruit. We continue to recruit top faculty from across the country, but not only to lead in these major roles, as you can see, whether it's the President of the American Academy of Ophthalmology, we heard from Dr. Edmond last year, whether it's the past President of the American Academy of Orthopedics, Dr. Bozick, or the President of the American Association of Obstetrics and Gynecology, Dr. McCones. We have the immediate past president here of the Anxiety and Depression Foundation. We have the fellow of the American Institute for Medical and Biological Engineering with Dr. Leah Harris. Of course, we have other Pew biomedical scholars with Dr. Arbel Harpak, who just received that award. And the White House fellow, Michael Hull, is one of our faculty. So what's important, though, these faculty also deliver care in our community and provide care to the underserved in our community. It is core to our mission, and I think it's important to recognize that shared commitment. And on the subject of recruitment, it's a point of pride for me that DelMed is directly or indirectly connected to attracting these 445 new doctors to Austin. This represents roughly 11% of Travis County physicians, and that's just in a short amount of time. And our practice expansion plan, which I'll talk about a bit later, will continue to attract another 200 physicians to Travis County, to Austin, through 2029. From these physicians and their teams, I think we've gained care capacity that ranges from basic to complex, includes cardiovascular care, advanced maternal fetal medicine for the highest risk pregnancies, more abdominal transplants, and starting soon, Central Texas' first pediatric stem cell transplant for children with cancer. And in the midst of that complex and serious care, the day-to-day care, the kind of care that many in our community go without, continues to be an important part of our mission and our commitment through our faculty, our students, and our residents. Dr. Allison Cahill is a professor in the Department of Women's Health and Associate Dean of Translational Research at DelMed. She's one of these top doctors, attracting top teams to bring new, more, and better care here to Central Texas. Allison couldn't be here this evening, but I'd like to share a video in which she talks about the specialized perinatology care she provides to our local patient population, including people with low income, in addition to leading multi-site clinical trials in the region to study procedures and devices to improve the safety of labor and delivery. So I'm going to hand that over to hopefully our video.
Hi, I'm Allison Cahill. It's great to be with you tonight. I'm a professor in the Department of Women's Health, and I'm the Associate Dean for Translational Research for DelMed School. Clinically, I take care of high-risk pregnancies, and scientifically, I really do general obstetric research. So really try and improve the types of things that we do during pregnancy and the postpartum period to improve how moms and babies do. The populations that I serve in my clinical work and my scientific work are really closely married together. So we really enjoy the opportunity to both take care of the greater Austin area here clinically, but also as a scientist, it offers me the chance to offer patients in those communities the opportunity to be part of research that they might otherwise not have access to and improve their own health outcomes. About 4 million people have a baby every single year in the United States. And if we have the chance to improve a little bit of that care, we could make an enormous impact. And specifically to our patient population here in the greater Austin area, we know that unfortunately a large proportion of that population unfairly carries the burden of greater adverse outcomes. And so the chance that we could actually test things that could improve those outcomes, and specifically for our population here, really is what I spend my days doing. Hi, I'm Allison Cahill.
Well,
It's great to be
you heard that. So thank you, Dr. Cahill. I'll just go back one other slide here. So physicians like Allison are one of the foundations of DelMed's next chapter as part of the University of Texas Medical Center, which we sort of refer to the umbrella term for our practice, research, and educational activities. And you may have heard or read back in August of 2023, we made a big announcement. That announcement included the fact that we were going to be bringing more care into Central Texas, and that included both the building of a hospital, a specialty hospital, that was going to be occurring in partnership with MD Anderson, and that work is underway with one architect, and really a commitment to frictionless care, and a commitment that we are not building a two-tier elite and not able to afford care kind of a hospital. It is a place that we are committed to providing our care to our patients. In addition, I think it's going to be important to recognize that this is sort of an extraordinary moment to see the convergence of the state of Texas, the chairman of the Board of Regents for the University of Texas, the chancellor and vice chancellor, the president of the university, the Dell Medical School, to converge around a commitment to expanding care in our community. This brings a chance for us to bring top talent. There's strong momentum. We do have an ambitious vision and this vibrant Texas capital. And in that regard, I want to share here what is the challenge. There's many challenges on the ground in Travis County. There is also the challenge that many patients for complex and serious care actually have to leave the city. If they can afford it, they leave the city to get that care. Whether that's for cancer, cardiovascular, musculoskeletal, or neurosciences, you can see that up to 5% out-migration in Dallas, over actually 26% in Austin. And if you can't afford that care, you are going without that care. And so there is a challenge here in Austin to bring that type of care to our patients. With that in mind, just kind of share here that the other element to keep in mind is care in the city is highly fragmented. Navigating this environment is unique. And you all know the challenge of navigating this environment in the absence of resources, people to work alongside you, to be able to understand what's where and how. And I think that fragmentation is particularly acute in this city. We cannot solve that problem with what we're doing, but we can do our role to contribute to it. And we can also be thinking about how fragmented care differentially impacts different populations in our community. I think this is only highlighting that the city is rapidly growing, and every element of healthcare in the city is anticipated to see continued growth. So we need to be mindful of when you're building a hospital to provide more complex care, you have to think about what's happening before, during, and after. And to just bring someone into a hospital and then send them out into the community without the resources, the support, the kind of post-acute care they need, you're really not making the major impact that you are aspiring to have. So this is our pathway to 2020, is how we get there. It's important to know that building UT Medical Center doesn't just mean building 2 hospitals. In fact, the build has already started, even though we won't break ground on this until 2026. We are in the process of sort of conceptualizing the experience. We will be looking to partner with all of you, actually. We will bring the community into this. We're in early phases. We're just trying to figure out who's talking to who, so it's early. But it will be intentional. It will not just be bringing Central Health and our partners along, but it will be engaging our patients, engaging our community in the design of this hospital. I think that's really important to be intentional about that. In addition, we're in the process of our practice expansion that over the next 5 years is going to include, I said, the recruitment of 200 physicians to join our existing clinical practice. In addition, we are targeting areas of specialties that are also important to areas of identified need by Central Health in primary care, surgery, neurology, psychiatry, cancer care. And we're working at this facility expansion enablement with the hospital, hopefully opening their doors as we close out the decade. The target is January 2030. And to guide this work, we began sort of our strategic planning process at DelMed, started about back in September, and we boldly say the statement, health starts here. But all of you know, health doesn't start here. Health starts in the communities where we work, where we live, where we're struggling with the various challenges of how we live. But we wanted just to be bold that we are committed to health. And to guide this work, we developed a strategic plan, which is represented from 2024 to 2030. And I think the first thing I want to underscore is that, and to highlight that, on the one hand, we talk about defining the future of health. There's a lot of disruptions happening in health. But we don't want to be seduced entirely by the digital, the technology. All that is important, but that also has a differential impact on our communities we serve. And in that regard, we, however, want to underscore that we are working together with our community. We call it out in our vision statement. As a world-class academic medical center, we will work with our community powered by cutting-edge technology and digital capabilities. We strive to set the standard for excellence in integrated care. We want to pioneer research with meaningful impact. We want to lead innovation in medical education, and we want to catalyze life science entrepreneurship. And with that, the mission, I think it's important to call out, we were very intentional about the second bullet, but as I look at this mission statement, to revolutionize how people get and stay healthy, we do need to build a sustainable academic health system. We are focused on meeting the needs of our patients, that it would be integrated across the continuum, that we think about the continuum of care. We want to embrace novel and collaborative solutions to ensure that everyone has a fair and just opportunity to be as healthy as possible. We want to be committed to empowering our patients, families, and communities to be active participants in the healthcare process through information, access, engagement, and agency. We aspire to cultivate transformative research, entrepreneurship, and innovation that leads to real-world impact, the kind of impact that matters to the communities we serve. We strive to equip our faculty, staff, and learners with the knowledge and skills they need to lead this next generation of healthcare and to lead the advancement and use of cutting-edge technologies, data, digital capabilities that serve the needs of our patients, our physicians, our healthcare professionals, our faculty, staff, learners, and importantly, our community. So I'm not going to go through the whole plan, but I just want to highlight several key elements of our strategic objectives. There are 5. One is around advancing the delivery of exceptional care. And you can kind of see elements here of calling out the importance of high-quality, person-centered care, that we really think about how data drives improved outcomes and experiences, that we build this hospital of the future recognizing how medicine is changing, and actually more and more care happens outside of a hospital. And we need to think of how that hospital will connect to the community, to the home, to the homeless. We need to think about championing models of care that really drive, not only reduce healthcare costs, but improve quality, experience, and value. I think it's the second bullet that we really wanted to be intentional about our commitment to our partnership with Central Health and this community, and that is empower opportunities for health. We want to pursue, and I use this word, and Patrick has heard me say this, but authentic, bi-directional engagement that supports community-driven solutions with impact. So easy, and Patrick has heard me say this as well, that to work on a community, work for a community, but it's something different to work with a community. And unless you're really thinking about that intentionally, you find yourself sometimes swooping in and out of a community, and you can pat yourself on the back and say, that was great. Or you could have some short-term impact and not recognize that if you don't continue that, it breaches trust in a fundamental way that actually sets you behind. So this concept of working with, we will look to Central Health and others within our community who really understand the community and use that information, but importantly, engage in a real intentional way here. We want to enable our patients to be active participants in their health and the health of their community. We want to invest in partners and programs that align with our mission to advance equitable access to care, and that we are designing data and digital solutions that prioritize personalized treatments and experiences. When we hop into some of the other objectives, 3 more, this part about training physicians and healthcare professionals to lead the future of health. The disparities in health continue to expand. Travis County and Austin is one of the areas of some of the fastest growing wealth and fastest growing poverty while the city is growing rapidly. It is a microcosm of what is actually happening in health across the country. That puts the responsibility on on all of us to really address how we're going to tackle that. But it also begins with training physicians out the gate of why this is important. And I can say with real pride that the medical school and the identity it had around addressing and advancing equitable health and health equity was something so palpable from the moment I came here. It continues to be central, and it would be a major reason why I, and I'm sure many others, have come here to be part of this, because the impact is significant, but the responsibility is also significant. In addition to training this workforce, we want to drive discovery across disciplines. Research isn't just this esoteric activity, it's where you bring cutting-edge treatments to our patients, to our communities. And when you think about the investments we're making in a medical school right now, two of the big areas we're focused on are community-based participatory research and implementation science. Why those two? Because the gap that occurs in developing solutions for a community often don't even consider them. They don't consider them in the stakeholders of the design. You design some digital app, you think it's great. You fail to recognize it's not going to ever be implemented because you've never thought about the community within whom or the people that are using these. So on the one hand, I think our investment up front in that space is paramount, and we look to leverage the strengths of the university to advance that work as well. And of course, when you think beyond the discovery across disciplines, we want to think about how you can catalyze innovation entrepreneurship. When you think about commercialization, it's one way to scale. You know, if things just stay locked up in a paper or a grant, it doesn't have the real world impact. We need to help people understand how to bring that impact to the communities we serve. And then I think finally, I want to move now into caring for our community. And specifically, I'm going to, move here for just a minute because I blocked through all this. As I want to work through some of our core areas of collaborations and permitted investments, starting with caring for our community. The clinical practice at Del Med is growing. We've seen about 90,695 unique patients since 2017. Nearly a third of those were seen in just the last year. We expect this trajectory to continue, to effectively triple the volume by 2027, with a commitment to ensuring our patients in the safety net population are a part of that expansion. In the last year, about 12,000 unique patients at UT Health Austin used MAP, Medicaid, or Medicare. That's about 38% of all unique patients. And at about 11% of all UTHA unique patients use MAP, 4% use Medicaid, and 23% use Medicare. And of the Medicare users, about 8% are estimated to be part of the safety net population. In terms of our partnership, in the last year, there's been over 4,000 unique patients at the Musculoskeletal Institute who've used MAP, Medicaid, or Medicare. Overall, it's about 59% of all unique patients we see. Again, you can see the distribution of MAP, Medicaid, and Medicare here. And in the last year, 59% of unique patients in the clinic used one of those MAP, Medicaid, or Medicare. In terms of partners in care, the Women's Health Institute, want to kind of elaborate here that in the last year, about 1,600 little over unique patients at the Women's Health Institute use MAP, Medicaid, or Medicare. Again, you see the distribution. You can see how many patients we've seen since our launch in 2017 and in the last year. I think it's important to also recognize, apart from care, the ability to co-recruit. And just in the last, we continue to increase our activities in co-recruitment because we share a commitment of recruiting those health professionals prepared to really commit to the community. That includes developing joint job descriptions, hiring, and cost sharing. You can see that we've now co-recruited 10 professionals, including 5 in GI, 3 in nephrology, and 1 each in pulmonary and hepatology. And we are currently co-recruiting in neurology and skilled nursing as part of that plan. More broadly, most of our faculty physicians provide care in the community. Actually, if you look at that total, of our 352 faculty members employed directly by Del Med, 75% work full or part-time in the community with a range of partners, including community care, Ascension Seton, and Integral Care. And this year alone, they contract to provide about 435,000 hours of care. They're also providing care in key areas called out in Central Health's Equity Focused Delivery Strategic Plan. Those are areas of primary care, cardiology, GI, neurology, and psychiatry. Faculty physicians are also joined by our 465 residents and fellows. They play a critical role In academic year 23-24, they provided more than 898,000 hours of care at 90-plus clinics and hospitals. 75% of these hours are at community care, Del Seton, Del Children's, or Ascension, Seton, Shoal Creek. And here in Williamson, Hayes, and Travis counties, this is where they're working. Burnt orange zip codes have practicing residents and fellows working in clinics and hospitals. Light orange zip codes are the new sites this year. DelMed also students spend about 44 weeks on 6 core clerkships, rotating at a number of these sites. They also operate the C.D. Doyle Clinic, a free clinic in East Austin that provides care for and underinsured patients, particularly those experiencing homelessness. Meeting with the medical students, I can tell you that this is actually front and center. In fact, when they are recruited, we prioritize service to the community as one of the critical elements in the phenotype of medical students we both attract and ultimately who come here. And you can see the distribution of hours since the medical school here graduated that first class in 2017 with over 25,000 unique patients, 29,000 patient visits, and over 7,000 of hours spent with patients. I think it's also worth pointing out, important to highlight some of these things. Apart from the matching across the top programs and many staying within this community, of DelMed's 5 classes who have completed the MD program, graduates in 3 of those 5 have been recognized with the Excellence in Public Health Award for their unique effort to advance public health and well-being. That is an important thing to recognize, and I think it's a testament to the type of students we train and the commitment they take not only during medical school, but as they move forward into their careers. I want to mention now about research and innovation, this next permitted investment as a core area of collaboration I want to talk about. So DelMed is home to over, I said, 86 funded faculty researchers, 241 active funded projects. Our footprint here continues to grow. And in fact, there's something called the Blue Ridge Rankings, which may sound not so relevant, but it's a sort of a measure of NIH funding. It also reflects sort of the ability to attract federal dollars to fund work deemed important here. And if you look at all the medical schools, between 2018 to 2023, Dell Medical School had the largest bump in ranking over that period of time. We still continue to look to grow that, but I think, again, it's a testament to this activity as an underpinning of many of the activities the medical school is working on. So I just thought I'd give a couple examples of research that might be helpful to think about. One is adolescence and young adulthood, as you know, is the age of onset for serious mental illness, and they engage in mental health care the least of all ages. Dr. Deborah Cohen, a faculty member in our Department of Psychiatry and Behavioral Sciences, led the creation of the Amplify Center, an integrated youth mental health clinic at Austin Community College. The center is designed to really be a low-barrier, one-stop integrated mental health center for young adults. And you can see some of the outcomes from this Amplify clinic, reducing less mental health, 85% with the suicidal thoughts reported reduction, and 52% improved in work, school, and daily functioning. Another example is Dr. Kate Remick, co-directs the National Pediatric Readiness Project, which helps to really help emergency departments evaluate and enhance their pediatric capabilities. Actually, most children seen in general EDs, and less than 50% of those EDs engage in pediatric quality improvement efforts, and her work is focused on how to really address that, to make the hospital ER ready to provide basic care to children, ranges from just $4 to $48 per patient, while significantly improving survival rates. Another example is most patients referred for kidney transplant don't live in the zip codes with the highest burden of end-stage disease. Conversely, areas with high burden of disease and lower referral rates are typically those who already struggle with access to care. I'd like to invite Dr. Joel Adler, an assistant professor in the Department of Surgery and Perioperative Care, who co-led a team that uncovered this, and that's doing even more community-based research in pursuit of fair and equitable access.
Thank you. That works, right, when I do the other one? Great. Thanks, everybody, and thanks to Dean Lucanetti for the introduction. And thanks really to the board here of Central Health for your interest in our research, and honestly, and probably most importantly, your work on behalf of the patients of Travis County. I can speak really wholeheartedly also on behalf of our clinical program. Through the Sendero insurance product, we've been able to transplant 6 patients. Of our 50 transplants so far have all had Sendero as their primary insurance, with actually, as of today, now 12 people active still on the waiting list. All those patients received a living donor kidney transplant, and thankfully all are doing very well. I'm a kidney pancreas transplant surgeon and a health services researcher. I joined DelMed back in November of 2021. My first day of work was actually the very first day our clinic was open, because of the medical school's mission to deliver innovative care within the context of the community that it serves. Building a clinical and research program here was an opportunity that was awfully hard to pass up, as very well described as what we're doing. And honestly, I couldn't decide if I was crazy to do it or crazy not to do it, but here I am. Our research focuses on identifying barriers to transplantation in Central Texas through early community-based participatory research. Some of our mixed methods work with over 300 patients and 20 of their caregivers. We found out that more than half of them speak Spanish at home, their median household income is less than $40,000, and uncovering really important barriers like low health literacy, high social needs, a lot around food insecurity, and poor quality of life compared to population norms for patients with kidney disease. Highlighting so many of these challenges, one caregiver noted that, quote, "We were also planning to adopt kids, foster kids, and have our own kids. But everything has stopped. We are just stuck inside not doing anything because our main goal is just to keep him alive. And we're not very old, we're in our 30s, we have a long life ahead of us." Moving on from there, we moved upstream to study dialysis social workers, the key people who ultimately refer patients to us. From 27 participants across 20 facilities, including many at satellite facilities, we learned about systemic barriers, including tensions between dialysis and transplant services, accessibility issues, and just outright discrimination. And what was a very interesting comment from one social worker, she noted, quote, "Sometimes just familiarity and confidence with navigating the healthcare system is a big barrier. Lots of immigrant folks have different backgrounds. Anyone with low literacy skills or low health literacy skills who does not have that family member support is not going to be able to deal with all the transplant communication and paperwork and self-advocacy that it takes. But our research is only worthwhile if it actually improves the care that we provide. We've, of course, begun the academic cycle of publication and dissemination, but we've actually really started to use those insights to improve the processes that we have and actually take a look at ourselves and figure out what things we have done as a transplant program to make these barriers worse for our patients and look at our own biases. With limited organs available, it's really crucial to minimize these barriers to provide the highest quality and most equitable care that we can. Our future work involves collaborating with referring physicians and developing a community advisory board to guide our research, or engaged partnership with both the community and with community health workers, and ultimately to develop interventions that address many of these barriers. Our goal is to ensure that access to quality care for patients with end-stage kidney disease is determined very much by their need and not by the barriers that they face.
Thank you, Jill. As you can see, the impact of that work and our continued commitment to advancing and investing in that. I'd like to now, working alongside clinician scientists like Joel, are our teams in education and training. It's another permitted investment and core area of collaboration. More than 230 students have now completed our Signature MD program. Many of them also get dual degrees. The MPH, the Master of Public Health, is one that is one of the most frequently selected by our students, and they can do that within the 4 years without adding a 5th year. In our most recent graduating class, 1 in 3 entered a primary care specialty, which is important to consider because there are about 83 million people in this country that live in an area with insufficient access to primary care. Furthermore, try to find a doctor who's a primary care doctor in this community. It is not easy to do for anyone. And so we recognize the importance of being able to expand those services as well. Delmed has now graduated 5 classes from its MD program. And of those 5 groups, I would just want to comment that our match rates, it's important. It's sort of a reflection of sort of how well you're training your group. They all match. Most recently, we've had, again, 100% match rate at this most recent graduation. We look forward to seeing how they'll continue to carry the spirit of what they've really developed and learned at Delmed into these other environments for the residency training. Graduate medical education in Central Texas is also expanding collaboration with Ascension Seton. Delmed, as I had told you earlier, has more than tripled its number of residency and fellowship programs to 47, and that we project an 88% increase by next year. This means a really important thing: more doctors for Central Texas, both now and in the future. Of Delmed's 578 residency and fellowship graduates who have immediately entered practices, Since 2015, nearly half of them have stayed in Central Texas. In fact, where you do your residency is strongly correlated with where you actually practice. One of the physicians we've been lucky enough to retain to Austin is Brooke Wagon, who was part of our inaugural class that graduated in 2020. She has since completed both residency and a fellowship here. We're proud to say that she's now part of our faculty teaching clinical skills as an assistant professor in our Department of Medical Education. Some of you may remember Brooke from her community work, which includes research on socioeconomic factors impacting the health of older adults living in low-income housing. Or from 2017, when she spoke to this board about her early experience as a medical student. Or you may know her because she was recently hired to work as a palliative care doctor here for Central Health. Brooke, thank you for being here. I'd like to join you to share a few comments.
Thank you, Central Health Board of Managers, to my dear friend, Dr. Zamora. I am grateful to be here for the second time. I remember well being here and being very nervous as a new medical student. But I want to tell you a little bit about myself because I think it frames who I am and why I've chosen to be at Del Med. I moved to East Austin in 2008 after building a home. I had moved to Austin in 2000, and I was in this neighborhood raising my kids, and I voted for Prop 1. I also drove Meals on Wheels for my neighbors with my homeschooled boys, and I got to know folks in Chalmers and Santa Rita and along 2nd Street because I chose to drive routes in my neighborhood where I could park my car at home after getting the meals on East Side and then walk with my kids to my neighbors and deliver them food. I had been pre-med in college, but I decided to not go to med school at that time to focus on my family. And in 2010, we brought our teeny baby home from Ethiopia as a 6-month-old. She's now starting Austin High in the fall, so time passes. Building a medical school for and in the community to care for Austinites was a mission I immediately resonated with. In a word, I was already a very rooted Austinite who would never have moved for med school, and I didn't have to because Del Med got built. I like to say that it was built in my backyard, and it really is true. So I became a med student in the inaugural class in 2016, and as a part of the Del Med curriculum right away, I was enrolled in interprofessional education, or IPE. It's a core component of the curriculum. And in the first year, it's med students, pharmacy students, social work students, and nursing students all across the UT campus coming together to understand, well, what's it like to work in teams, right? And Del Med recruited for team players who wanted to think in teams because they wanted to think about us as a part of the community, right? You're not a doctor who commands from on high. You're a member of a team who works with and for other people. So those other students are engaged with us in the first year, but Del Med has this IPE curriculum for 4 years. And in the third year, every single Del Medical student every year since the school opened has had to engage in partnering with a community nonprofit to work in a way that benefits that nonprofit. So not surprisingly, probably, I reached out to Meals on Wheels and said, hey, I have this group of 5 medical students and we'll commit to working for you every week. One of the other classmates who was the co-president of the class with me had worked at Meals on Wheels before joining Del Med. And I asked her, well, who should I talk to? So I met with the right person. And I said, hey, do you have anything back burner that like with 200 hours of like competent labor, you could get to the front burner and benefit, our neighbors? And she said, oh my gosh, absolutely. We really wanted to start a program where we help people prevent falls by doing PT visits and we do home repairs, but we've never had the info to power a study to prove that we should get the grant. And I said, well, I think we're your people. So I wrangled my med student buddies and we called hundreds and hundreds of home dwelling community older adults who spoke English and Spanish. I did all of my surveys in Spanish. We powered a study. They applied for a St. David's Foundation grant, and they now have this program where you can, as a Meals on Wheels recipient, if they deem you to be a high fall risk, so you're not walking around and never falling and you're also not wheelchair or bedbound, they will send in a team of 3 to come into your home and to keep you from falling in the future. It's like direct work that was a part of my Del Med curricular experience. And what I think about is that was me and 5 people. There were 10 other projects like that in my class, and that happens every single year. So Good Apple was founded as a collaborative project also with a Del Med student and his team. The other thing I want to talk about, which Dean Lucanetti talked about a little bit, is that I got to spend my whole 3rd year as my main work just in East Austin interviewing my neighbors about what it's like to age in place in public housing, what it's like to experience healthcare, how to navigate the system. Does it feel isolated to live in public housing? What is your community like? What are your relationships with your neighborhood like? I interviewed people in English and Spanish, and that work was very insightful and really grounded me in and for the community in a new way because I'd never done qualitative research before. I was learning to think in more community level ways. It just was a new thing for me. And that was the work that I did in my third year alongside rotating in Dr. Zamora's clinic every week as a primary care student and then working in Meals on Wheels. So my entire third year, I could walk from my home to Zamora or Central Health or to Chalmers. You may imagine, based on what I've said, that I never imagined or thought about leaving Austin to go to med school or to train. So I did what they called suicide matched. I only applied to one med school. I only applied to one residency. I only applied to one fellowship because I've always wanted to stay here and work in this neighborhood. I had not thought about it very much until you mentioned COVID, but my first day as a resident was actually in the COVID ICU in what became the DelMed Center of Excellence for COVID. Every single one of my patients that day spoke Spanish. I worked for 28 hours. I never sat down. I spent all those 28 hours on the phone with families because I'm a bilingual doctor. And it was profoundly affecting, and I don't talk about it very much because I can't do it without crying. But I think that the ways in which Del Seaton and the residents and fellows and faculty mattered is never going to be encapsulated, and none of my class will talk about it. I ask people like, hey, do you ever want to do a podcast about COVID? And every one of us just starts crying because all we did was watch people die. It was really hard. But I felt like I was in the right place at the right time with the right skills and the right empathy, and I'm really grateful that I was there. It probably hardly affected my decision to become a hospice and palliative care fellow. And so what I'm doing going forward, and I think the way that I want to wrap up training the workforce of the future is that I've always had a great love for Central Health, and I've accepted a job already to be a part of the new specialty care clinic at Rosewood Zaragoza, where I'll be a part of the palliative care integrated program, where I'm going to be working alongside cardiology, pulmonology, renal, Dr. John Weems, who's an addiction medicine doctor. Like, it's an integrated program. And when we first were admitted to DelMed in our class, I don't think they do this anymore, we were given a t-shirt where you said, how do you want to revolutionize healthcare? And I was like, well, that's audacious. But I wrote on there, I want to provide concierge level medicine for Austin's oldest poor. And that's the job that I'm going to do. And I'm really grateful to your support for DelMed and what it's doing. Thank you.
Thank you, Brooke.
And we're lucky to have you, Brooke. If you remember when you presented to us back then, I said one day I'd hope to see you in the chair spot. And I still hopefully someday you will be.
Thank you, Brooke, and I think also just a testament to really embodying the power of the medical school, the power of the medical school working together, the type of people that are part of that medical school, and how that is generative and how that continues to give back to the community and our partnership with Central Health. There are two more areas of our education training work I want to comment on. Doctors like Brooke, who stay in Texas here centrally to practice, have the opportunity to learn at DelMed throughout their careers. Last year, we hosted more than 130 continuing medical education events focused on topics from infectious disease to health equity to value-based care. And upstream from our other medical education programs is support, exposure, and access to health professions for the younger learners in Central Texas. We have some really outstanding pathway programs here, you can see. 6 of our programs, some examples which you see listed on the slide, serve over 500 students from high school to undergraduate per year. To date, our pathway programs have introduced 4,500 middle and high school students to careers in health sciences, so educational activities and mentorship with health professionals. But again, it is the flavor of how we're introducing them into careers in medicine, and we're continually to reinforce the very themes that you heard Brooke speak about at that very early age, and hoping we continue to inspire that workforce of the future. Finally, I want to talk about our core collaboration, advancing health by advancing technology. We have a 2-part data strategy. I don't want to get into all the details, but data matters. Knowing what happens to your patients and where they are matters. On the one hand, electronic health records give you some sense, and we're in the early stages at DelMed of implementing a new electronic health record. But importantly, I talk about data for discovery and data for health coordination. And that's where some great work that has been going on now together with Central Health and others to develop toward a healthcare data platform that is called Watershed. I'll tell you a little bit about Watershed, but it enables you to know where your patient has been. So why is that so important? When you have multiple places and multiple front doors a patient can land in, and then they come to you, you don't know they've had 3 CTs, 4 of this, 3 of that. You just have none of that data. How can you really impact their health outcomes without knowing that? So that brings us to Watershed, the ability to access information from recent encounters with other providers at the point of care. This is a vital component of realizing the system of care strategic, imperative, and central healthcare equity plan. Watershed Health is a community-wide data sharing platform designed for just this purpose. What does it mean? It provides real-time exchange of information between doctors, better care coordination, better patient outcomes. So at a time when we're all excited about the potential of data and AI, but at its fundamental core, we don't even have the data to know where our patients have been. The other thing Watershed does is connect them with social services and other support in their community. So with that, I just want to share a comment by Mike Ryan, our CIO at DelMed. Data platforms like Watershed are good medicine. Providers in any participating setting are aware of recent test results, diagnoses, and medication changes, and as a result, they provide better care for their patients. I'm excited to say here that we've been working together. DelMed has assigned a participation agreement with Watershed and implementation across UT Health Austin, Central Health, Community Care, and Sendura. This is all imminent. We are actually the catalyzing team, and we look to bring the other major healthcare providers in this city on board because we believe, as Mike Ryan said, this is good medicine. Last things here is just a section on community initiatives. And here, in particular, I want to speak to some of the work that we're doing again together around supporting our community. A cornerstone of that is the care continuum for people experiencing mental health issues at the Austin State Hospital. We have Sydney Harris here as well, and she's been critical in that, opening this year after DelMed-led effort to reimagine it. The evaluation of community mental health needs is ongoing following the hospital completion, and we have an opportunity for partnership in areas here, such as clinical services, operations, and care model design. In addition, in 2018, the Texas Health and Human Services Commission contracted with DelMed to lead a collaborative to redesign this facility that serves 26 counties for adults. I should go back here on the previous slide. For adults and 75 counties for children. In terms of the diversion program, DelMed and Travis County are pursuing partnership opportunities to support a 3-phase development of the diversion ecosystem to help prevent criminal justice involvement for people with mental health illness and substance abuse disorders. Last year, DelMed published a final report outlining the findings of this effort that serves as a foundation of broader work now in progress. There are tremendous opportunities here, conducting extensive program evaluation of recently funded Travis County diversion efforts, defining data use cases to inform the county and other opportunities to divert people from the justice system, informing the county on data use agreements needed to maximize diversion efforts in the county, providing expert consultation for the design of the operations of diversion facilities, and developing a strategic plan on diversion efforts for the county. And I know this is also a passion area, the area around respite, medical respite. And DelMed and Central Health share a commitment to close the gap in care for some of Travis County's most vulnerable. Those are those patients experiencing homelessness. And I recall when Patrick sort of laid it out, the whole process, you can't just intervene in one place. You need to think of that whole continuum and that how you provide that care, but ultimately if you don't have the housing to support, at the end of that, you're sort of just back in the vicious circle. We are excited about continuing to work in this space, defining this work as we develop a shared understanding of effective patient engagement informed by best practices, building the bench, establishing the best practices to address health-related social needs, plus create educational opportunities and internships for students, and to co-design an evidence-based evaluation plan with associated metrics that address clinical access, patient recruitment and retention, and clinical outcomes across demographic groups. Often problems with mental health, let me go back here for just a minute. I want to speak also a little bit further about the supporting the care continuum, the permanent supporting housing healthcare collaborative. This was jointly designed by the Ending Community Homelessness Coalition and DelMed. The Permanent Supportive Housing Healthcare Collaborative is bringing integrated primary and behavioral health support to residents of more than 1,000 permanent supportive housing units in Austin. These residents are people who were formerly experiencing homelessness. And I think I know Tim Mercer was here last year, but I think it's worth highlighting his powerful statement that we are working to create a seamless, integrated, and person-centered system of care that will make it easier for the residents of these housing units to not just remain in their living spaces, but to thrive in them. My nearly last slide, promise I'm almost done here, is really around the space of cancer care, combating cancer in our community. I want to really focus here for a bit that CONNECT is one of 5 programs led by our Department of Population Health to improve cancer care in Texas. It aims to improve access to colorectal cancer screening and diagnosis, particularly in vulnerable populations, including people with low income. Texas has actually one of the lowest rates of colon cancer screening in the country, and we're aiming to change that here in Travis County. This is funded by the Cancer Prevention and Research Institute of Texas, CPRIT. This initiative is creating a statewide network of resources for patients needing screening. In Austin, the program is working with local FQHC organizations to provide a stool test by mail, as well as ensure that patients who have a positive test or at high risk are able to undergo a colonoscopy and additional evaluation. These are the kind of programs, though, that it's not enough to screen. You actually need to really think through the continuum. Now you have a positive test. Now you need to get the treatment. Now you need to be sure that you can provide access to the care. Because I think sometimes I've seen plenty of examples where you just sort of stop at screening. You can feel good about that, but at the end of the day, it's the whole care continuum that follows that. While still expanding, the program is already making an impact, as you can see from some of these results. And other programs focus on areas like breast cancer screening and treatment for the underserved women, plus smoking cessation and lung cancer screening for high-risk patients ages 50 to 80. And the progress we're making in that effort, I think it's really exciting. I think it's really exciting to begin to see a vision for how the care we're continuing to expand from UT and Del Med will work closely and in collaboration with serving the needs of our community, with still an intentional focus on our safety net population, and that I look forward to continue to work together with you to expand and improve our ongoing partnership for the benefit of the communities we serve and communities that have really placed their trust in us. I thank you. I thank my colleagues who've joined me tonight. I thank our speakers who I hope have sort of highlighted and spoken from their heart. You can feel the passion that is there. It is authentic. And with that, I'm happy to open up for questions, comments, and I'll pause. Thank you.
Thank you so much. We really, really appreciate all of you. This is very, very impressive work, and we appreciate the chance to talk with you. What I'm going to do now is go around. I'm going to start with Manager May, if maybe we can pull this down so we can see her. If she's on, Manager May, are you on? I know you had a question you wanted to, so I'm going to have you start and then we'll go around. Are you with us?
Yes, I am, except you can't see my picture because the host is controlling the picture, the video here.
Okay.
But I'm here.
Okay, why don't you go ahead and speak while we're trying to figure out the video.
Great. Terrific.
Okay.
Good evening, everyone. So I just have a basic question. If we could have you elaborate a little more on the services that you're providing regarding women's health. In the past, and as fractured as our system has been, we've had various healthcare clinics devoted to women's health. And over time, we've lost a lot of them in our community. So I'd like to learn more about what you're doing in that area. And a two-part question with respect to that has to do also with the work that you're doing as it pertains to cancer screenings and cancer care for women, in particular, because Austin in the past, I don't know if the statistic still holds true, but in the past, breast cancer has been the leading cause of deaths in women here in Travis County, second to lung cancer. So I'd like to hear a little more about what Dell Medical School is doing in that area to improve those situations.
So I think important here that this is one of our two master service agreements regarding care. The one was in musculoskeletal, one was in women's health. As far as that effort, I sort of spoke about the fact that we've really, since 2017, have expanded to over 16,776 unique patients that have been seen in our women's health clinic. And when you think about that total, over 15% of them are MAP patients. And overall, I think I commented that 31% of our patients either have MAP, Medicare, or Medicaid. That being said, the specifics of the care being given, I didn't bring one of my women's health. Isn't there anyone from women's health here? Are you able to speak to that at all? Or maybe Alan can comment on that because you're part of that with us. Do you want to speak to that?
Sure. So that's generally the complex.
Wait, John, why don't
why
you
do you come up to
come
that?
up here so that,
I put you on the hot seat.
and Manager May will, these folks will answer as much as they can, and then I'm sure
Sure.
they'll follow up.
Yeah.
Okay,
Indeed, thank you.
okay, go ahead.
Hi, just very quickly, the women's health work is primarily focused on the complex gynecology. You all have heard from Dr. Amy Young previously, who helped us develop that program. And it treats a variety of conditions that typically haven't been available to our patients in other settings. But I believe the UT faculty here also provide a substantial portion of the services that are provided for obstetrics in the community care setting as well as in the hospital. So it's pretty comprehensive, Manager May, but happy to provide more details.
Thank you. Appreciate that.
Wait, we have someone
We have
else who's.
we have one other comment.
One other comment.
Thanks. Jewel, Dr. Mullen?
It's nice to see you all again. Jewel Mullen, Associate Dean for Health Equity. Just briefly, and specifically with regard to cancer screenings in women, Dell Medical School, I think mostly through Dr. Kiran Shokar, contributes still to the work of the Pink Bus that was established to also expand access to mammography screenings for women when some of that access was lost. And one of our women's health faculty, Dr. Yvette Williams-Brown, has received a grant from our office to pilot the use of a pocket colposcope to try to improve access to cervical cancer screening for women in sites where they usually can't get treatment. So there's other work that's going on to try to fill those gaps.
Thank you.
Good to hear. Thank you.
Thank you.
Thank you. Okay, I'm gonna go around the room. I'll start on this side, and we'll go around once if we have time. We'll go around twice. Would you like to go first? And we have about a little more than 30 minutes, so think in terms of 3 or 4 minutes.
Okay, first of all, thanks very much. Appreciate the opportunity for you to come out. I have just two quick questions. Well, not quick, but two questions I'll see if you can answer. First of all, in terms of the data of graduates or residents that have come out of that program, is it possible to get the information based upon demographics?
So we do have that data. In fact, up until January 1 of this year with SB 17, some of the reporting has been modified and how we report it, but we do have that data. It's available, and we could share that data with you. As far as the specifics today, I don't have it right in front of me, but I'm happy to provide that data to you.
So for those particularly of racial and ethnic
Yep.
groups in Travis County.
So what I can tell you, though, those are no longer permitted categories, so we are actually looking at trainees that coming through from different elements, so specifically rural, low socioeconomic status, like other areas that we're being able to collect data on. That being said, we do have that data. In fact, it was reported extensively within our LCME accreditation.
Okay, well, it'd be helpful if we could get that. I appreciate that. Another
Yeah,
quick-
and that'll be, I can provide that.
You can provide that? Okay.
Make a note of that.
And the other question is a comment. And as a board member representing Travis County
Yep.
residents, and I know it doesn't relate to you particularly, but it does relate to the state of Texas and its policy on DEI or lack thereof. I have real challenges rationalizing for the citizens for us to pay out $35 million to an institution who has been directed that it cannot look at all of the multifaceted aspects, particularly those of color, for which the population that we collect dollars for, fund. So I guess my question is there a way that we can work to be able to enhance those type of service training and service delivery to ensure that in Travis County, where those residents are of color, communities of color, that we're comfortable being adequately served by the Dell Medical School?
So I think it's important to underscore that SB 17 did not limit the ability to address health equity, health disparity. In fact, that remains still a cornerstone of our mission. It's called out in our mission, and there's nothing about that was impacted by SB 17. The closing of DEI offices that occurred across the state of Texas is related to that, related to other DEI programs that were developed with race, ethnicity, gender as being an exclusivity component of a particular student group, let's say, or an activity. That being said, I want to reassure you that we continue to be strongly involved in these areas. And maybe, Jewel, is there anything you want to add to that from your perspective?
Well, I appreciate that, and I'll end with this by saying, if we could get data to sustain and support what you're saying, that would be very helpful to have.
Yeah, I mean, hopefully you could also see really concrete examples. An example of what you heard from Dr. Adler around our transplant program and data around our programs in terms of homelessness. But I think what you're getting at is, what sort of data do I have access to on the basis of race and ethnicity specifically in our programs? All of our pathway programs are completely intact. We have all that data we can provide you. As far as how that data breaks down, I'm happy to follow up with our team and provide that to you to the degree that I can under the current regulations.
All right, thanks very much. I really appreciate you.
Thank you.
Manager Mullen.
Thanks for being here, Dean Lucanetti, and also to your team. The presentation was fantastic. You know, it's obviously really dense, and I think that's helpful for us. I really just have comments more than questions, and so I'll keep it as quick as I can. Sure. Some of the things some of the notions I appreciate from this presentation, of course, our ongoing discussion of our partnership are first, you know, that the growth of obviously a med school is a non-linear thing, you know, the early days and the early years are scaffolding and sort of building infrastructural components and administration and what have you before there's sort of tipping points that occur for, I think, more tangible outcomes of a medical center to be available to us. So that's, you know, kind of the first notion that I appreciate. And then the second notion is, I think, in turn, the ROI of what the med school and the med center can bring to our community, our county, and particularly our communities that are experiencing disparities way disproportionately in an unjustifiable way. I think that ROI is also nonlinear, and I take that away from this discussion as I look at sort of what physician recruitment looks like year 1 versus year 10, and you know how that sort of starts to add up and roll. What will that look like at year 25, right? And so I think that there is a ton of benefit, and with particularly your presentation and discussing the areas of care that simply are not available to anybody here in our community. That's compelling to me, and it's also compelling to me that those who it's our shared mission to serve in many ways, the economic, low income folks at 200% of poverty level, they also will be benefiting from the medical expertise that's brought to our community. I believe that there has to be some better way for all of us together to help quantify that. And I don't know if it's the most ingenious healthcare economist in the world who would need to study kind of what that ROI looks like. What is the cost of the absence of certain kinds of care? What is the cost of what have you, or what are the benefits of bringing in a lot of the services that are coming online, and a lot of the treatment options that are available to folks who are on MAP, Medicaid, and Medicare. So I think I just want to put that out there that, it would be helpful for me to see that somehow quantified. And it cheapens things to quantify health outcomes in dollars, but it's what we do. And especially when we're talking about an investment that's being made between the partners. And so I just want to put that out there. And then finally, two things stood out to me among the very, very many impressive items that you shared, but I think the human-centered design when it comes to treatment solutions and research, working in the communities to develop solutions with communities, is particularly compelling, and it's sad to me that that's not how we do it, but it is also a fact that I'm pretty familiar with. And then secondly, watershed. Watershed seems really neat, and I would love to be able to deep dive in that more another day. and where that model has been successfully employed, what sort of learning there is from there before we go here. But I love the notion of the partnership and that sort of the leading partnership, because I think it provides critical mass to be able to bring other partners on. So that's really neat too. So thanks. Sure.
First of all, thank you for your comments, and I think you highlighted a couple key points. The non-linearity of how you start out as a medical school and kind of grow, the complexities of the multiple components of a mission of a medical school, that cross-practice research education, the ability to identify metrics that matter, and how do you measure that, and how do you actually measure the cost you avoided by providing interventions early. That is very difficult to do. So you can see the cost when a person is in the chronic latest stages of renal disease and then end up having to be sent to another center outside of this city because they can't necessarily get it here, and the costs and the healthcare system on the individual, et cetera, versus being able to put in the kind of interventions early on. How do you measure that dollar amount is very difficult. So what you measure is the cost utilization, but it's hard to measure the cost you didn't spend. So that's one challenge, and I think that that's where you can start to look at access. And so although it's not a number, it can tell you, are you improving access? And then finally, how do you measure outcomes in a meaningful way on the health of the community you serve? How do you look at how many patients are, if you look at the amputation rates in diabetics, if you look at, these bizarre incentives, and why are amputation rates in certain places much higher than others when the care that we've talked about providing at the level of, interventions early with podiatry and endocrinology, and why we're looking at all that, measuring that is very difficult to do, but I appreciate the complexity and the need to get both quantitative numbers around this, but also what you highlighted was the recognition that there are qualitative and frankly things you can't really measure, but that doesn't obviate the need to be focused on the outcomes themselves and meaningful ways to measure those outcomes. It's something that I know Dr. Mullen, we talk about quite a bit, like how do you really know you're making any difference? Because we can say individually we can see differences, but at the level of a population, at the level of a community, and I think that's where we look to partner more intentionally around those types of things with some shared agreement of what that looks like. But it's not easy to reduce to a number, to an hour, to a patient, to a dollar. It's just not, but it doesn't mean we don't have to do our due diligence to be stewarding that. It's a reason that our strategic plan called out also two values, stewardship and humility. Stewardship, that we are given the honor and the privilege to steward the dollars that come from Central Health in a way that meaningfully is going to impact our communities. And number two, humility, that there is an issue of how you bring yourself in the cultural humility of recognizing the power differentials that exist when you engage in patients and the clinical humility that you need to bring to bear. We teach that at the core of the students that we train. We call it out as a priority for our strategic plan, because at the end of the day, if you don't have those factors, it sort of becomes like a business. I mean, that's not what we're not in the business of medicine. We're in the business of improving care for our community.
Thank you so much. I really appreciate your talk, and thank you all for coming and sharing your stories. I really appreciated the compassion and the empathy that you all possess. Really greatly appreciate it. Now, a couple questions that I have. It comes to cancer care, and that is an area that it is quite fragmented in our community, and no one knows how cancer care is delivered for our underserved. And in scope of MD Anderson coming to town, what is the relationship, and would we have access? Our patients have access to that care? Because I know how would their system differ from Harris County to Travis County. So I think that's an area that we are really interested in. We want access for our patient population to receive the best quality care, and not, you mentioned earlier, not to build a system that's not a two-tier system. So appreciate more on that scope and how it would be delivered, and so that was one. And also in terms of your research and expanding diversity in research, all of our patients have access to research that you have? Is it within our in community, in our FQHCs all across? So that's an area I just wanted to know how you know, you're doing great research, but our patients, do they have access? Are we expanding the diversity of it? And I think those are really the main questions that I have, and I know there will be a lot, but given the time that we have.
Well, I appreciate the questions. So I think it's important to call out, as MD Anderson is building a facility here and bringing cancer care into Austin, in addition to our specialty hospital, when you look at our first panel of work streams, everything from, build to research to technology, there's a specific work stream, community/cancer prevention. It's called out as an area that we are excited to be partnering together with the community, with Central Health, with all of you. What does that look like? It's early days, but we also did speak, so Chris McKee, Chief Strategy, and Rosanna Morris, Senior Vice President at MD Anderson, and myself have had conversations about ensuring that, one, there's sort of a coordinated approach of working together with Central Health, and also that we don't have a scenario where there have been relationships built through DelMed and the community, our cancer prevention program, and Dr. Shokar, that we just want to also avoid sort of going around that, like, having multiple people kind of pinging into the community. We want a cohesive, coordinated strategy. So I believe that there will be, and I know there will be opportunity to more specifically speak about what that strategy will look like. At the moment, I just was aware that Central Health, I think Monica had shared, was having a conversation with MD Anderson. We're all going to be at the table. That ensures that we have a chance to bring our mission of the medical school, Central Health's mission, and MD Anderson's planned build here into the city, all to bear on how we're also going to address care. So it's a general answer, but I can't speak specifically
I understand.
from MD Anderson, but I can speak for us at DelMed. We, securing one of the largest cancer prevention screening grants here, that's not just research in a paper. We have increased the number of colonoscopies, over 16,000 screenings, 23 cancer diagnoses. That involves 36% of our MAP patients. That is an example of how a research grant or research then also change and can improve the care we give. That leads me to your next question around research and access. It's a tough question because that is both, one, ensuring a couple things. That travels all through the approval process of research at the level of an institutional review board that often can develop criteria for studies that are actually excluding some of the most vulnerable, not intentionally, but just based on how sterile the population should be. They can't have this disease, that disease, this age, all these various things. Two, access to make sure that they can be in studies without leaving work, or how do you actually bring them into studies? You have to think about that all the way through the continuum. And I would say that I really feel strongly that we also have programs that call out specifically health disparity, health equity type of research projects. Dr. Mellon spoke about that. But maybe I would ask Dr. Adler to speak from your perspective, and then maybe Dr. Mullen from your perspective on this point.
Certainly being able to design work and to engage with the community is something that we're all trying to be able to do. And I think that it does require a really intentional aspect to the design and the way that we're doing it. And I think part of that, from us in the transplant perspective, and I think about transplant in a couple different ways. I think one of which is, we're the end game for many people, right? Just by definition, end-stage organ disease just comes to that. And then thinking kind of what that looks like upstream and all the people that we haven't had the opportunity to meet yet and work, right? We only see patients who really need a transplant in our clinic, but what about the prevention aspects and all of those parts too? So I think that is a really key component of the way that we're all thinking about it, and something that certainly we are thinking about as well in the transplant program.
Thanks. Dr. Mullen, Evan, anything?
Thank you for your questions. You may recall that our health equity strategy from 2019 and 2022 includes a specific strategic priority on establishing a health equity informed approach to research. Some of the things that are encompassed as strategic objectives, we're actually now doing a deeper dive in, having hired consultants to determine what measures we should actually use at DelMed to establish our baselines and then track our progress for actually making that happen, which has included conversations with our Vice Dean for Research around what's the best way to ensure that in every one of our academic/research departments, the people responsible for research really understand what a health equity informed approach is. But someone on my team also sits on the IRB, and we've started having conversations around what does it look like to assess an institutional review board proposal to assure that equity is reinforced and not lost. In other places, people have had to flag issues such as making sure not speaking English is an exclusion criteria. So something as specific as that, but much more subtle issues as well. So in the spirit of also saying we really are serious about impact and want to be able to measure things, we are moving to the next step of proposing measures that we can adopt and hold ourselves accountable to.
Thank you.
So with the rapid growth of Austin and bringing in MD Anderson to the city, what are y'all's plans on expanding the medical school?
Well, that's a good question. In fact, I was just asked that recently. With the LCME accreditation, we did not feel that this year or next year would be the time to expand, but we are having conversations of expanding what that would look like and projecting that. We're in early days of that at the moment, but I do think there's an opportunity to expand, and so as part of our growth, which sort of done this, and now we're sort of in the hockey stick phase of what we're doing over the next 6 years, that will be an area we'll be putting additional attention to. So I would anticipate that over the next 6 years, we would probably see the class grow at least by potentially up to 10 more. That's our hope. Also, we're looking at bringing additional MD, PhD program into the medical school. This is a medical school dropped into a tier 1 research university, and the power of that university and the assets and expertise it brings, and the reality that they talk a lot about now about the new stethoscope is data science. In some ways, not to minimize the use of the stethoscope, but our ability to also train and prepare those that will help guide us through that, because we're not all data scientists, we're not all AI experts, but there are several that could really benefit and help shape this future. So when we talk about defining the future of health, if we aren't playing an active role in training and then shaping it, we will be reacting to it, and then we'll try to figure out where our communities were left behind. So one other point I want to make about that is, even as we think about digital health, et cetera, our whole focus, together with actually Craig Watkins from the IC Squared Institute, we're actually talking about a kind of institute that would be built with the stakeholder and the community in the design of these solutions moving forward. And in fact, that is an intentional way of bringing implementation science, community-based research into these kind of questions. And so I think my main point here is just you grow the medical school, you continue to not make sure you don't lose sight of your mission, but you have to adapt to a rapidly changing world around you. And when you think about the idea of tequity, technology and the digital divide, and you see all this stuff happening, if you don't have people that are not only trained in understanding how you will leave whole populations behind, if you're not training that into your school, if you're not advocating in the design, that is where I really look to together with the medical school, bring technology and digital, but standing right alongside health equity and how you can actually exacerbate disparities. You can exacerbate bias. That is central. We don't lose sight of that, and there is some great thought leaders throughout the university and also at the medical school, and it's that kind of intentional approach to who we recruit, the work we do, who we train, and the need to bring those additional skills so they can be the champions for all of us and our communities.
First off, I want to thank you for a wonderful presentation. I think expounding the value that the medical school brings to our community, it's a really great value for the money that we invest. Thank you. And thank you. I did have a comment about the tracking of the data and the value. I'm a primary care physician.
Yeah.
About the bang for the buck early on in the process. And I think they did studies out of Massachusetts where they looked at that after Mitt Romney passed healthcare reform there, where initially there were enormous expenses. And I think that they track that data, and I think that'd be great data for us to see. I'd like to make a point, because Manager Motwani noted about sort of the value, the ROI on investment and providing services here. As a doctor has to not infrequently refer patients outside of the community for, say, a transplant.
Yeah.
Imagine our patients who are perhaps not particularly educated, they're poor, they don't have a lot of support systems. We have to send them to Dallas or Houston. They don't speak the language, et cetera. To provide, I sent a patient recently to MD Anderson Houston for melanoma in the eye. And, that's very difficult. They're poor. And I think that bringing that here and bringing Central Health really along with that brought enormous value for our community. Because that's a very, we can't really see the difficulty because we navigate the system daily. But imagine someone who's a day laborer and they have to go to San Antonio to get a kidney done. It's really problematic, and I think that's a value you really can't put $1 to. It's really an element of human suffering that we should try to relieve. So, but I think it's wonderful you're all doing that. So thank you.
Yeah, I appreciate that. I think it also underscores why, bringing that level of care is so critical into our community. And then, of course, we're sort of in a unique environment. I don't know of anywhere else actually in the country that is building, largely from almost a greenfield, a system of care, an academic medical center, and doing it at this rapid scale and pace. But the greenfield environment means and the fact that we have this partnership and we're working side by side means we can be thinking about the system of care as we're building it rather than trying to back into it. We know the challenges our patients face. I think the key is how we hold ourselves accountable through that process, while also needing to develop a sustainable model of care for our community. From that standpoint, that I think is the challenge, but it is the prerequisite for what we see to be the academic health system that we can contribute in partnership with all of you.
Yeah, I thank you, and I'd like to. I was doing emergency medicine in the Valley, and one of the executives down there did a thing where they essentially integrated, much like the watershed system down there, because the literacy level was so low and whatnot that people didn't know what this surgical scar was from, what pill they took, whatever. And so I think that the value to that, I think in terms of, I hope that UT really works hard to integrate that, because to not have to repeat the CTs, the MRIs, to, go through this process, you do build a sense of trust with these patients that, I'm having another CT scan and whatnot, and I think it's invaluable, and I really hope that that does occur very forcefully here, because I think the miscommunication, the lack of communication really breaks trust with patients.
And important to that, I just want to speak to the fact that the medical school is just one of many schools within the university. School of Nursing, Moody School of Communication, School of Social Work, School of Pharmacy, College of Liberal Arts, that are heavily invested into this space of wanting to address and improve care and address health disparities. When it comes to communication, we have a relationship, DelMed, with Moody around how to improve communication of care to patients at their bedside within the community. You bring this world-class communication school, side-by-side medicine, together with nursing. I think there's a whole other power of where this medical school landed and the power of that university and its commitment alongside us that I don't think can be underappreciated. It is really a significant catalytic opportunity to bring that all together. And so when I speak about the work in this space, I want to be sure I underscore how much we're actually working right alongside pharmacy, right alongside School of Nursing, right alongside School of Social Work. Most recently, Dean Alan Cole, who's the Dean of School of Social Work, he's just been appointed the Deputy Director of Health, Humanities, and Technology. Currently, together with the School of, Dr. Mullen and the School of Social Work, we are jointly recruiting bioethicists in this space. We are interested in really attending to this and bringing the other schools along and putting leaders in a position of influence to be able to not only recruit faculty, but understand that relationship of how we're working with the community. In this case, it's around technology and humanities and health disparities.
And I think the issue when the nephrologist spoke about, how they got someone roped in to agree to dialysis, right? they didn't speak they didn't speak English well enough, then having the social workers there amends that some of diversity that we've sort of been forced to sort of ignore now. But I think that's a wonderful thing to bring that power together, really to help get people who may not trust the system as it is anyway, or can't communicate correctly through language barriers.
And I think, I'm sure Dr. Mullen could elaborate further, but, you know, her thoughtful, discerning wisdom as we also look, what are the environments we're training in? What get into the ground and understand the gaps, and what are we actually doing to close those gaps? Some of these things are really not so complicated to address, but if they're not on the radar, they just continue. So communication is a huge element. And that also comes you back to research. If you have a consent form that a patient isn't translated into their language or isn't really understood, you know, it goes on and it just keeps amplifying the challenges. So again, appreciate the comments.
Thank you so much.
Thank you.
Hi.
Hi.
Welcome to all of you, and thank you all for being here. I'm going to be the $35 million person that's going to question you and ask why we don't have a better accountability. Why don't we have better accountability language or reporting language so that we can see exactly how many of our MAP patients, which is our targeted population, not necessarily Medicare, not Medicaid. They've got services, they can come in and get the services at our clinics, but our MAP population. And you serve 771 out of about 5,200 patients, unique patients, according to your records. $35 million a year. You've been getting that money for at least 10 years. That's $350 million. And the depositions that were given by your staff, they told.
So Cynthia, Manager Valadez, your questions are appropriate, but we're not talking about the lawsuit here, okay?
No, I'm not talking about the lawsuit.
Well,
What
you
I
just
wanna
mentioned depositions.
I'm sorry, for the context, she's a new person, and I appreciate hearing from you, but the only reason I stated that was because there was leadership from your Dell Medical School that stated that they did not know or identify or have a system in place to be able to ascertain whether one was a MAP patient or a Medicaid patient or a Medicare patient or a private insurance patient or whatever. That was a fact that was stated. And I'm just telling you that those things mean something to me because I live in that level, in that socioeconomic level. And when you're getting our tax dollars and telling us that, well, we don't have to report this to you. As a matter of fact, with some money, we can give it to the chancellor's office because they're doing so much for our MAP population. That doesn't exude a lot of confidence in me in what I hear from bureaucrats. But I am telling you that I greatly appreciate your tone and the way you have come here and your staff has come here to tell us exactly what they're doing, how they're committed to working with Central Health as a partner, which is something I hope that you all do in a more qualitative and quantitative way so that we can know exactly what we are getting, what bang we're getting for our buck. And so I just wanted to make that statement. With respect to Dr. Adler, your comments, I've worked in the school system for over 40 years as a volunteer on the Special Education Committee, Citizens Advisory Committee, and the Bilingual Citizens Advisory Committee, et cetera, et cetera. And what I found is that the crack in mental health and behavioral health starts at home from the time a child is born. And to wait until they're young adults, they have missed an academic basis for receiving supports and identification. A lot of that has to do with the way that diagnosticians are trained and how responsive teachers are to the needs of the students in the classroom as they are overwhelmed with the bureaucracies and the requirements that are placed upon them in order to make sure the students and their tests and the students in their class pass their tests, so that I can determine as a teacher whether or not I'm going to get a pay raise or even a contract renewed. Those are facts. And so as we look at that, it's like when we had the floods in Duff Springs. We had children that could not be around a fountain, a water fountain, because they were panicked. They were traumatized by the water. Okay? Those are facts. And those things we've known that have been in place since 2012, 2013, along with the consideration for Proposition 1 and the creation of the medical school. Yes. So these are things that we would, if you're truly interested in working as a community partner for especially our poverty populations, which is where you would be able to see the real differences in people's lives, we would ask that you take into consideration those kinds of things, because they will be very telling as to what they are missing at home. We have kids that are going with their parents to serve as interpreters in their doctor's appointments, so those kids miss out on school. That's a fact, because we just don't have the parents' trust in the interpretation or translator systems that, well, let me put you on the phone, or let me, whatever. Those are huge barriers, especially as they don't even have a way to get to the appointment. So please take those things into consideration. And as we build a collaborative system that will address the needs of our poverty population, ultimately raising the quality of care and the level of care, of health, that our community has for Travis County, and I would say that can be taken out to the counties around us, because we are a racist, segregated system. That was the way it was created, to do that, okay, to keep out whom we did not want to dilute at the top. So just keep that into consideration and understand that there are many people that still are untrusting of what UT has to say to us, myself included. But I love and see the value of what you all can do for Central Health and for our poverty population, because that's why I'm here, and that's why I'm saying this to you. And I'm sorry, I didn't want to.
No, it's okay.
But I just, for context purposes, but it's so refreshing for me to hear your tone and the words that you're speaking, and the words that your doctors and your staffs are speaking the way here at Central Health, so we as a board can see this. But there's a huge number of people out there that are just thinking y'all are very good, polished politicians, bureaucrats, diplomats, giving us the same kind of message, telling us what we want to hear in order to buy into whatever it is you want from us with those with those public dollars that we get, because we're going to continue to get those tax dollars, and that's going to be a continued source of a private public entity to access in order to do whatever it is they want to do, because they hadn't asked us whether or not we could have any input into the development of what it is that you are doing. I hope I'm not speaking out of turn, and I don't mean any of this with any malintent. I'm just wanting you to understand that this is, I'm here to be an advocate, and this is the man that taught me how to be a better advocate. Whether I am or I'll never know. But anyway, I just want to thank you for your words, for hopefully your commitment, and please take into consideration as we build new contracts, new partnerships with new entities that come to town. Let's make sure that we have language in there that is accountable, will hold accountability, we'll have accounting and reporting language that will make sure that our population and our taxpayers know exactly where their dollars are going and what they're being spent on, not somebody's real estate in a medical school for a professor somewhere. So I just want you to understand that. Thank you very much.
No, I appreciate it.
Thank you, Manager Valadez. Let's, did you
Well, I'd like
wanna-
to say a couple comments.
Okay.
First, I can hear the passion, the commitment, the pain related to the challenge we face in caring for the most vulnerable in our communities. We each have a role to play. We play it in different ways. When it comes to what we as a medical school can do, tackling the burdens of society, we have certain roles. I can also say there are no violations of the law and no deficiencies in how Dell Medical School utilizes the 35 million. That being said, working together to identify ways that we can demonstrate the impact in both linear, quantified, semi-quantitative, whatever ways, we have to continue to work on doing that. And as far as actually the only thing I would say is, I don't know, my background is such that you kind of know what I'm emoting. I mean, it's very hard for me to just have another agenda. You can read it, just why I wear that. And that being said, I could never stand in front of this board or come to this institution if what I was about was just polished politician to just feed you a bunch of baloney. I couldn't live with that. I wouldn't do it, and I wouldn't have left a career of 27 years at the Mayo Clinic in order to do that. In fact, one of the central reasons that I left Mayo, in addition, was a recognition that this community could benefit from a new system of care that mattered. In Rochester, Minnesota, it's 100,000 people. This is a city that is one of the fastest growing cities in the country. And to bring the spirit of a union of forces, which the Mayo brothers would talk about, which is in my DNA, requires it's this union of forces, and each of us has a role to play. We cannot solve this problem alone. We also need to do it as a collaborative team. So I will continue to strive for ways to take the assets we have, the trust you've put in us, the resources you've given us, the talent, the expertise to make a difference. But I can't solve that. In fact, we can't solve that alone, but we can hold ourselves accountable to fight every day to do the right thing and to lead with integrity, with humility, and the privilege and honor of having these dollars to play a role in shaping the future of the care we bring into Austin, Texas, to be a model for the nation.
I just want to very quickly respond, just very quickly.
Okay, we're way over time.
What you can do, because of the expertise that you carry, because of the fact that you are the University of Texas in the state and in the capital city, is that you can bring all the taxing jurisdiction partners that are supposed to be responsible for the varied social determinants of health, or life, as I would state, and make them commit to the development of a plan that each of us will know what our part and our responsibilities are, and make sure that we all agree to it and comply with it, that we work on it, that we do it together. But it's not happening in a vacuum. It's not happening if I just talk, let me have my staff person talk to your staff. No. You all at the top need to get together and do that. And that doesn't mean me. And so I just want you to understand that we've got 175 to 200,000 uninsured in Travis County that are not met.
So Manager Valadez.
So please take that into consideration. Thank you.
Manager Valadez, I think a follow-up conversation would be fabulous here. So you guys have, I appreciate the conversation. It's a great conversation. I'm just going to have to move on. But I do think some follow-up conversation would be very helpful and very interesting. I know you're probably up for it. And maybe you would be up for it too. So, Dr. Zamora?
Chair Kitchen, thank you for the time. I'll make this brief. I know in the interest of time, we're going to make it brief. Dean, thank you for coming. Thank you for your work. And this board has heard me say this multiple times. It's about the patients. It's about getting the patients, just like my friend here next to me said, it's about getting the patients what they need. And thank you, Brooke, for your vote for Prop 12. Because that, when Mr. Heinrich and I went, Clark, there you go, Clark Heinrich and I went barnstorming from town hall meeting to town hall meeting. We told our taxpayers, this is not about brick and mortar. This is about buying services from the future physicians who would be coming into town. And we knew, when I spoke to Senator Watson, then Senator Watson, now Mayor Watson, that we would be able to bring the best of the best.
Always on call.
Sorry. We'll bring the best of the best to Austin and get more specialists here. You know, for Prop 12's main reason was to decrease the wait times for our patients at MAP. You know, before Prop 12, we had a year and a half wait time for an orthopedic surgeon to see one of our patients. It's down to a month. Y'all are doing great work. I'm gonna stop there and thank you for your time. Thank you for your physicians who came, especially Brooke. I love Brooke to death. I met Brooke before she went to medical school.
Thank you.
I'm gonna close this out by saying that, I want to echo what everyone has said, and I want to say thank you. And I want to say, I hear you and I can feel your sincerity. And that is very much appreciated. I do think that what Manager Valadez has brought up and what others have brought up is important. You can help us tell the story. So, and we need to spend a bit more time thinking about and collaborating with you on how we do that. Because it's important for the public to understand, both from an accountability standpoint and just from the caring standpoint about what it is that you do. So we'll work on that. I think we need to do some follow-up. I'd love to, if it works for you, to have some opportunity for some more conversation and also some more brainstorming about how we can talk with the community. And as you are well aware, we've got folks on this board who are everyone on this board is very passionate, and everyone on this board has connections to the community, and they're here as an advocate. So
Well, I
we want to
appreciate
help
that.
you. We want to help you get the word out.
Thank you, I appreciate it.
Did you want to say
Could
something?
I offer just a few words of appreciation?
Yes.
It's really truly a privilege to be here to hear the remarks tonight, to hear the conversation. Just want to say a personal thank you to you, Claudia, Brooke, Joel, Jewel, Ryan, Sydney, Daisy. I'm so sorry. and Paul. To be here like this speaks volumes. I echo your sentiment, Chair Kitchen. I can feel the intentionality. I think that really matters when the work that we're about is building trust. I can also feel the optimism and the challenge to think about these next 10 years. You're entering a J curve hockey stick, and so are we at the same time. And I deeply believe that we are here for consonant mission, values, vision, and you spoke about the care continuum. Together, we complete that care continuum for our patients, I think. We talked about, you used the word equity, which is the notion that there can be leapfrog innovations for equity. We don't have to go up the chain in the same way. We can deploy continuous glucose monitoring, some advanced analytics, and proactively anticipate and address problems, even perhaps before a patient would have raised their hand, if left, without that ability to precisely target and proactively. We can build a health system like none other for our patients and really rapidly close that gap of equity together. And so the last thing I want to say is it's a point of pride for me and honor to lead an organization that has been a founding partner of the medical school, and that these last 10 years have been a wonderful foundation, and I'm excited for the 10 years to come.
Well, thank you, Patrick. And I just would close that moving forward, as we tell our story, we continue to recognize the various components that make that story, that we work together, but the story still has a lot of chapters. And there's a lot of work and a lot of writing and a lot of doing. And again, recognizing how we can do that in a collaborative way without losing sight of the patient at the center of what we do, why we do, all patients, that we think of the system of care we want to build that considers the continuum. And then we recognize the most vulnerable, the most disadvantaged, that in that process you have the humility, the appreciation, and the intentionality to try to address that, realizing we can't solve it all. But if it's not in our radar in everything we do, then we would never be able to do it. That being said, I am grateful for this opportunity. I'm honored to be part of this team, and I look forward to continue to work with all of you. Thank you.
Thank you. So managers, I'm going to move on to our next item, our item number 3. There's no motion necessary, and there's no presentation. So item number 3, I would just refer you all to your backup, and that is update on higher education workforce. Could folks please, could everybody just please take it? We're still continuing with our meeting. So it's an update on the higher education workforce recruitment, the employee engagement survey platform, organizational growth, and joint tech. So I just refer you all to that backup. So we're now going to go into closed session. on items 4 and 5. And David, I think there's nothing happening on 6 and 7, so I think all I need to do is read 4 and 5, right? Okay. It's just 4 and 5. So, okay, item number 4, receive an update on optimizing enrollment in the MAP program. Item number 5, discuss updates on matters related to the performance review contracted by Travis County, including delegations to the president and CEO to execute necessary agreements between Central Health, Travis County, and Mazars. So I announce that the board is convening in closed session to discuss agenda items 4 and 5 under Texas Government Code 551.071. Yes? Ready? Okay. All right, we are going back into open session. It's July 24th. The time is 9:03. We're taking up our last item, item number 8, which is to confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for August 7th at 1 p.m. in this location. At this time, I'm ready to accept a motion for adjournment from Manager Valdez, seconded by Dr. Brenton. All in favor?